I might have to duck out briefly.
Okay. All right, welcome back. Thank you for your patience. As we stated before the break, some of you weren't here, so welcome to the new folks. We're running about a half an hour behind in our schedule, but we're going to accommodate all the topics and all the presenters and all the public comment on today's agenda, I think, adequately. So with that, Mr. D'Angelo, if you want to come on up and get close to the mic. I'm sorry, D'Angelo. I said D'Angelo. D'Amour. Sorry, morning. Come on up and get close to where you're going to be presenting. So I'll give a little preface to this for the committee so they'll understand kind of where this comes from. So the Judiciary Committee, in conjunction with the Governor's Office and the Department of Corrections and the Executive Branch, has been doing a justice reinvestment, I think that's the right word, study. And they contracted with the Council of State Governments and to do a big, broad look. And one of the things that came out of their study, and certainly this will be gone in more detail, was the role that substance abuse and mental health will play in our justice system if we can maybe make some modifications and improve outcomes for people and our system. So I think maybe that's not a very eloquent synopsis, but that's why they're here. I invited them to come and give us the substance mental health component. They'll probably put it in context of the entire program. So if you're on if you've been following any of the Judiciary Committee, you might have seen some of these materials already. If you're not following them, then some of this will be new, but it's in the context of some work that's been done, and they've been doing a lot of good work. And I just wanted to get this committee kind of up to speed on some of this, because obviously substance use and mental health is a part of our interim charge, and this being another component, I thought it was appropriate. So with that, the floor is with the CSG, and there were three presenters coming, and David got the shortest stick, or the only ticket that was still viable, and got here. So David, the floor is yours. Please introduce yourself and proceed.
Thank you very much, Mr. Chairman.
Would you have, please?
I'm not sure if this is on.
Maybe pull it a little closer also.
How's that?
Perfect. Thank you.
Okay. Thank you very much, Mr. Chairman. My name is David Demora. I'm a senior policy advisor with the Council of State Governments Justice Center. It is, in fact, true that originally there were going to be more of us that came today, but as it turned out, your committee meetings were back to back. And so we have a team of 4 folks, and over the course of the last several months, we've been crisscrossing your state. My colleagues were here last week for one of the other committees, and I came for this committee today. The reason that they asked me to come for this committee today is that my particular area of expertise has to do with the areas of risk assessment and the areas of behavioral health. And so it made sense that I come and talk with folks today.
Would you pull that mic even a little closer? Some of the mics are more sensitive to others, so I'm sorry you'll feel like you're going to be chewing on it, but
not a problem. Is that working?
That's better. Thank you.
Okay. If I can just make that work and look at my
slower
screen.
And slower and maybe a little slower and right into the mic, please.
How about that?
Perfect.
Okay. Let me know if it stops working again as I look around at folks. So as I said, I'm with the Council of State Governments, which is a region-based organization, and it fosters the exchange of ideas to help state officials shape public policy. We have 4 regions. We cover the country, and there are multiple areas that the Council of State Governments looks at, including economics and finance and elections and transportation and criminal justice. And there are multiple products and services that we as an organization provide to the states. The Council is a nonprofit, nonpartisan membership association of state government officials, and we engage with officials from all 3 branches of government. The CSG Justice Center, where I work specifically, provides practical, nonpartisan advice that's informed by the best available evidence and data. In the time that I have today, I'm going to try to succinctly talk about 4 areas. I'm going to give you a brief overview of justice reinvestment to make sure that we are on the same page about what it is. I'm going to talk about the role of drug-related offenses and how they're straining the criminal justice and community substance use and mental health systems here in Wyoming. I'm going to talk about the strategies to connect people on probation and parole with timely and specialized community treatment. And I'm going to talk about what's been going on in terms of Wyoming's justice reinvestment approach. And as I said, in a very timely and succinct manner. Justice reinvestment is a data-driven approach. It is used to reduce correction spending and to reinvest some of that savings in strategies that can decrease recidivism and can increase public safety. It's supported by funding from the U.S. Department of Justice's Bureau of Justice Assistance, or BJA, and also the Pew Charitable Trusts. There are actually two components to justice reinvestment. There are those, what we call phase 1 and phase 2. The pre-enactment component includes developing a bipartisan interbranch working group, meeting with leaders from around the state, getting a lot of information, reports, data, speaking with folks, and then beginning data analysis, analyzing the data that we get from across the criminal justice system, engaging stakeholders and getting feedback and input from them to add to the data that we've collected, and then the development of policy options. Phase 2 is post-enactment. When a state has enacted a number of policies, they can then apply for phase 2 funding, at which point we are then able to help them with the implementation of those policies and also monitor key measures and outcomes to make sure that, in fact, the anticipated outcomes are what they are receiving. We've worked with 29 states, some of them twice, on the justice reinvestment approach. We are currently working with 11 states in either phase 1 or phase 2, as you can see in this chart here.
Thank you. Donuts tomorrow.
In the Wyoming justice reinvestment has been a bit compressed compared to a lot of the work that we do in terms of the timeline. And so you can see here that from last May to now, we have been doing a lot of work. We have been here multiple times. Our team, different members of our team have been here multiple times, starting with the initial analysis, then going into more detailed data analysis, the shareholder engagement, looking at policy options and looking at the impact of those analyses. And we've had both on-site meetings and multiple phone calls. My colleagues have testified before the Joint Judiciary Committee 2 or 3 times, as well as multiple calls. And we've certainly had calls with different folks from here. And I've been at some meetings with some of you in other venues. So we've been doing a lot of fairly quick work over the course of the last several months. That work has included gathering a lot of data. Basically, we were able to get over 1.2 million individual case level records. And we were able to get a lot of aggregate reports and a lot of data tables. And we've been able to look at things like admissions into prison, releases, population snapshots, program assignments, sanctions and rewards, risk and needs assessments and results from those, offense information, treatment completion information, the demographics of folks in terms of who's getting what services and who's doing what things out there in the community, and geographic information. We have sort of crisscrossed across the state, if you will, to help us understand better the criminal justice system here in Wyoming. Our staff have gone to various places. We've observed a number of different supervision contacts between officers and probationers. We've taken tours of the adult community correction centers. We've observed parole board hearings. We visited a number of jails of different sizes and met with sheriffs and staffs that are involved in both in those jails and in patrol. In October, we visited Jackson and really focused there on the intersection of the criminal justice and substance addiction and mental health systems there. Plus, I was able to meet with some of the judges in the area, the mental health centers in the area, and the sheriffs in the jail in the area. So again, we've spent a lot of time trying to speak with many stakeholders throughout the state over these last several months. So why are we doing this, and why is the issue of justice reinvestment going on? Well, the problem, if you will, is that Wyoming's prison population has reached capacity, and it's projected to grow by 200 beds by 2023, which will push the population to 109% of current capacity. Already, 88 people are being housed in a prison in Mississippi. 55 to 75 people are being housed with in-state contracts in different jails at any given time. And there's 140 people on inmate status that are in the adult community correction centers. And those are not even depicted in the current population and forecast. So the numbers are concerning, to put it mildly. When we look at what that means, it means that Wyoming taxpayers potentially face a $50 million plus price tag in order to accommodate the projected prison growth by 2023. That includes the total cost to contract 201 more beds by the end of 2023. That would be about $21 million. The cost of increasing the current capacity by 280 beds in order to accommodate the projected prison population and bring the folks home from out of state, which is costing a tremendous amount of money, by the end of 2023 would be roughly 30 million or more, giving you a total price tag of about $51 million for contracts and new construction to accommodate the projected prison population growth that you are seeing. By the way, spending to accommodate that growth is already underway, about $2 million a year to house 88 folks in Mississippi, $1 to $2 million for the in-state contracts with the jails, and $16 million in proposed new construction in Torrington. So already a significant amount of money is going out to try and deal with this problem and this issue. So why is this problem and this issue coming up? Where's it coming from, and how can we think about doing something about it? Well, I'd like to talk a bit about the issue of drug-related offenses and what that's doing here in Wyoming. Wyoming's had a dramatic increase in drug arrests. In fact, it was one of the largest in the United States in recent years. It's had a 42% increase, in fact, in the number of drug arrests, the 8th largest increase in the country. And to be clear, drug arrests are defined as state or local offenses relating to the unlawful possession, sale, use, growing, manufacturing, and making of drugs. And they make up 16%. They made up 16% of all arrests in 2016. And by the way, that did not include the DUI arrests, which also obviously have to do with substance abuse issues. When we look at that, over a 4-year period, the drug-related case filings increased significantly. And what you see here are the increases, and you certainly also have increases in assault and in violent crime, as well as in drug manufacturing and delivery, but also drug possession. And I'd like to particularly have you pay attention to the drug possession line, 107% increase under felony, and the drug possession line in misdemeanor of a 41% increase. And if you move from the percentages to the numbers, you see some pretty large numbers there. I mentioned that not because the other issues are not important. They are when we talk about violent crime, when we talk about focusing on those areas. But when you look at the increases in drug possession, it ties very strongly to some of the problems that we've seen that have developed in terms of lack of available intervention or not enough of it, and the need to have a response that really hits and effectively responds to those folks who do have drug addiction issues. In 2000,
So hold on, David. Let's take some questions as we go, because you're going to give a lot of some numbers through this, and people want some
Certainly.
clarification. So, Senator Boner.
Okay, so just 2 clarification questions real quick on
Please.
the previous chart. First of all, when you get into the felony offenses like theft and burglary, are there any indication how many of those were drug or alcohol related, or is there any way to kind of get down to that level of data?
Go ahead, please.
it would be very difficult for me to get to that level of data. This was determined by what was the highest charge at the time of offense. And so that's how this chart came about. I'm going to turn and ask Steve, is there a way to get that data broken down the way that the senator just asked?
This is Deputy Director Lindley. If you want to just go ahead and so that people can hear you, because we are streaming live.
Mr. Chairman, Steve Lindley, Deputy Director of the Department of Corrections. To answer Senator Boner's question, there's not a way to get at that. Kind of additional information that may point to that. Currently, about 70% of the inmate population needs residential substance abuse treatment, and about 20% need intensive outpatient treatment. So 90% of the inmate population needs that level of substance abuse treatment, which may help point to the answer to your question.
Thank you, Mr. Chairman.
Anything else? All right. Any follow-up questions? Representative Sweeney, thank you, Deputy Director.
Thank you. Thank you, Mr. Chairman. On slide 15, that's up, both on the felony side and misdemeanor side, you know, it appears the large increases are drug possession on the misdemeanor, and then both drug possession and drug manufacture / delivery. Is there any correlation to Colorado?
Go ahead, Mr. DeMora.
I'm sorry, is there any correlation to Colorado?
Colorado as far as recreational use of marijuana?
Mr. DeMora.
I would say, Representative Sweeney, if there is, we're not able to point to that. The increase certainly has to do with a wide variety of different drugs, including meth, and not just marijuana. We don't have a way to show in terms of possession whether that directly relates to Colorado or not. It could, but we don't have that information. As far as drug manufacture and delivery, we know that that crosses multiple state lines, but the ability to tease that out by which state line is a level of accuracy that just does not currently exist.
Thank you. Please proceed.
You asked me the question about the issue of violence. Following up on that in some ways, in 2017, over half of Wyoming's prison admissions for new court commitments involved nonviolent offenses. And specifically, this is for court commitments. So for new court commitments coming from court, about half of the prison admissions involved nonviolent offenses. When we then look at probation revocations and we include those, the increase in drug offenses is even more apparent, excuse me. We're looking at about a 75% increase in possession driving that. And so while if we look at just new court commitments by itself, there's a drive there, there's an increase. It's not too big, but it's still driven by a significant increase in possession, 46%. But then when you look at the issue of folks who are revoked from probation, your numbers increase pretty dramatically. And again, I'll ask you to remember that as we talk a little bit later about the impact of what happens when certain things are not available, and the only place that those services are available, or the only thing to do for those folks is to have them incarcerated in order to assure they get certain treatment, or that the public is safe. In FY 2017, more than half of prison admissions were due to supervision revocations. Again, an important point. More than half of them were due to supervision revocations. There was a 12% increase in probation revocations, a 55% increase in parole revocations, and actually a slight decrease in new court commitments. And so when you look at the increases that are being, what's driving the increases, we very much see this in terms of probation revocations and parole revocations. And I want to make a quick point here that is true for any other thing that I will say. This is not an issue of problem probation officers or problem parole officers. This is an issue of there being some systemic problems in which people are making the best decisions they can make given what they have available to them. And so I really want to make that point, because as we talk about what needs to happen, it has to do with what is available to the system to be able to make the decisions they need to make to assure that people can be successful and the community can be safe.
Senator Scott, just a moment, David.
Just a technical question for those of us who don't regularly deal in this area.
Yes, sir.
What's the difference between a parole revocation and a probation revocation?
Please go ahead.
Certainly. A probation revocation means that the person was sent to probation from court and is on probation, and he is then revoked, and the court makes a determination that his probation is revoked. A parole revocation means the person was released from the Department of Correction and was given parole by the parole board, and the parole officer then determined that there was a problem, that the person needed to go back, and the parole board determines that in fact that is the case, and his parole or her parole is then revoked.
Thank you.
The majority of supervision revocations cite condition violations rather than new felony convictions. But in fairness, the full story is a bit more complicated than that. When we look at violations for probation, about 84% of them were violations for what are called technical violations, meaning not new crime. When we look at parole violations, about 87% of them were what are called technical violations, or violations for conditions, not violations for new crime. Now, to be clear, these fall into three buckets. Technical violations related to substance use is one of them. Technical violations that are unrelated, or at least not directly related to substance use, including absconding or a new misdemeanor arrest. And then there's also a bucket of folks that, frankly, we couldn't from the data tell what the reason was for that technical violation, other than there was nothing written suggesting there was a new crime that had been committed. It's also important to understand that when somebody is violated for a technical violation, it doesn't mean it's the first time they did something. There may have been a problem or two or three along the way, and some time has passed, and then it reached a point where what would be needed to make a difference simply wasn't going to be available, wasn't going to happen, and the violation is put in place. And so those things need to be kept in mind, because it's not so simple as one event happens and a violation happens. That's typically not the case. But the problem with those violations is that Wyoming is spending about $30 million a year incarcerating supervision violators, the vast majority of whom were revoked for violating conditions as opposed to committing new crime. About 21 million of that is for probation revocations, and about 9 million of that is for parole revocations. So a tremendous amount of money is being spent on those revocations. And secondly, of course, we're talking about taking up space, taking up beds in the prison system, where we have a shortfall, and a perceived greater shortfall coming very soon. Another way to think about it is that about 30% of the prison population is made up of folks who have violated either probation or parole, as opposed to being there for new crime. 22% of that 30% are probation violators, and 8% of that of those folks are parole violators. Why is that an issue? Well, there are the obvious issues in terms of cost and in terms of efficiency, if you will. But the other issue really does ultimately relate to long-term community safety. When we look at the data, treatment during incarceration is not as effective as treatment that people get in the community. When we look at treatment that people get during incarceration, it will lower recidivism by about 5 to 10%, assuming good assessment, good programming, good transition planning. When you look at treatment that's provided in the community, you have a 20 to 30% recidivism reduction, again, assuming good assessment, good programming, and effective supervision. I again want to make a point here. This is not to suggest treatment in prison isn't effective or shouldn't happen. If you have somebody who is a risk to the community who needs to be incarcerated, it'd be pretty important to give that person treatment before they got out, so that there was a base of something that happened before they start seeing somebody in the community. But for those people who are problematic, misbehaving, doing the wrong thing, breaking the law, but not threatening other people while they are doing that, it is less expensive and more effective to respond to them with effective community treatment than to start that treatment behind the walls and then move them out. Does that make sense?
Senator Scott.
Mr. Chairman, we conducted an involuntary experiment in this area where they cut back in the course of a governor's budget cut when we first hit our big shortfalls. We cut back on the substance abuse treatment. And my question is, I thought that was inpatient treatment that got cut back on, and the result was a jump in recidivism. Am I wrong? Was it outpatient? How does that experience mesh with this data?
Mr. Dumore.
You are not wrong, but that's not complete information. You're absolutely correct that there was a cut in prison programming, and that increased recidivism in terms of supervision failure. It is also true that there was a cut or even funding in terms of community programming, and that folks are not, which I will get to soon, folks are not getting to and accessing the necessary level of treatment. So some of your failure is coming from the inside, some of your failure is coming from the outside. So it's actually a combination. I believe at the time that that discussion was being held, that folks had not yet looked at the outside component as well. They had only been looking at the inside component.
Thank you. Please proceed.
So I'd like to talk just a little bit about strategies then to connect folks on probation and parole with timely specialized community treatment. Nationally, to start there, there's a large number of people who enter the criminal justice system who have behavioral health needs. When we look at serious mental illness, for example, about 4% of the general public suffers from serious mental illness. But when we look at state prisons across the country, about 16% of folks have those problems. Jails, about 17%. Probation and parole, about 9%. That's serious mental illness. And to be clear, that just means what used to be called Axis 1, the most serious kinds of mental illnesses, psychosis, schizophrenia, et cetera. When we look at substance addictions, the general public, we're looking at about 16% of the general public. When we look at state prisons across the country, we're looking at about 53% of the population. At jails, about 68% of the population. Probation and parole, about 40% of the population. So nationally, we see this problem. Wyoming is hardly alone in the numbers that Deputy Director Lindley was mentioning to you a little while ago. Addressing those needs can be somewhat complicated. The fact of the matter is it can be challenging for a lot of reasons, not the least of which is there are a number of different areas that we have to pay attention to. And given the time that I have, I'm going to try to say this in as brief a way as possible. There are folks that have a lot of what are called criminogenic risk needs, things that drive them directly toward crime. Folks who have a lot of substance addiction needs that may end them up in the criminal justice system, even if they don't generally think in a criminal manner, and folks that have both of those things mixed together. All three of those groups end up needing some kind of intervention. They don't all need the same intervention, and some of them might need different components of that. The picture that you see in front of you are all of the different areas that can be needed. That is not to suggest that everybody needs all of those things. But when you have the individual that does need that particular thing, the absence of it makes the other responses ineffective. In other words, if somebody can't get to substance abuse treatment, no matter how good the treatment is, it's not going to be helpful. If somebody gets to substance abuse treatment, but they still have a lot of what's called criminal thinking, things that lead them toward crime, and they haven't gotten that type of intervention, then all the substance abuse treatment in the world by itself will not make a difference. So the idea of this model is these are the things we need to think about. Not everybody needs all of them, but we need to see that they are available when necessary. There are challenges across the whole country looking at this area. Just to be clear, there are funding limitations, as we know, not just here, but everywhere in the country. There are practical barriers that come up, things like transportation. I was talking to folks in Jackson who were talking about how clients coming from literally from the other side of the mountain and the challenges of what that was like to be able to get there and what happened during the winter months and what happened when they missed more than 2 sessions and how that could be problematic. So the very real, very practical things that have nothing to do with whether or not that individual wanted to be involved in the intervention. And then there are workforce and capacity shortages. As we've talked to folks around the state, there are different places of the state where even if they had the program, they don't have enough trained folks to be able to provide that program. And again, Wyoming is certainly not alone in those challenges. Some of these are bigger for Wyoming than others, and in other states, they have some different challenges that are larger. But at the end of the day, effectively responding to these folks means that we've paid attention to these sort of 3 big areas. And when there's an intersection of the 3 of them, paying attention to all 3, substance addiction, the criminal behavior thinking, and the mental health treatment. The particular driver in Wyoming appears to be the substance addiction need and the combination of the substance addiction and criminal thinking. Those seem to be your 2 biggest groupings and biggest combination, with a much smaller percentage related to the issue of mental health treatment and specifically needing mental health treatment. And The referrals for treatment by probation and parole actually bear this out. If you look at this, the two largest referrals that people make to treatment, whether we're talking about folks who are on supervision, felony probation, misdemeanor probation, or parole, the biggest the biggest source they all refer to is for substance addiction treatment, all three of them. The second biggest is for criminal thinking treatment, if you will, the cognitive behavioral treatment. So certainly the assessment of the supervising agents and the referrals they are making bears out, I believe, the previous slides that I was just discussing. One of the things that Wyoming is very fortunate about is that it does have 18 private nonprofit community behavioral health providers. And you contract with all of them to deliver outpatient, in some cases also residential, behavioral health treatment in every county in Wyoming. Now, in recent years, and Senator Scott, to your question earlier, in recent years, while funding in some centers has been flat because of programs for specific populations, others have had sizable reductions in both instances. And in both instances, the amount of funding available for the specific population I'm talking about, the criminal justice population, has decreased. The characteristics of the population seeking treatment, as well as their assessed needs and appropriate level of care, do vary across the state. It's not the same everywhere in the state, not of no surprise to anyone. As an aside, I have spoken with community behavioral health providers in almost every state in this country during my 40 years in doing this type of work. And one of the things that struck me in my early conversations with the WAMSAC and through all my conversations was their willingness to take these folks as clients. With many community mental health centers, to be very honest, with many community mental health centers that I talk to, and they have in their mind that somehow the criminal justice clients are different than theirs and they shouldn't be taking them. That is, of course, not accurate. It is not the case. But I would like to say, and I would like to make the point that here in Wyoming, your community mental health centers have stated very clearly, no, we get that they're part of the folks we should be seeing. And yes, we're willing to see them. And we understand that they have some needs that our other clients might not have because of their criminal thinking and excuse me, and criminal backgrounds. The Department of Correction and the Department of Health collaborated to analyze the overlap between the supervision population and people accessing treatment. So it started out by looking at what's the population of folks we have under supervision, what's the population of folks that we have accessing the behavioral health centers. We wanted to look at the proportion of people with known behavioral health needs from the perspective of the criminal justice system that access services through the centers. We wanted to look at the proportion of people accessing centers in Wyoming who are on supervision. We wanted to look at the difference in cost or volume of services between folks who are and aren't on supervision, and the benefits of investment in treatment in terms of reducing returns to prison. So the first thing that a member of our research team and the research folks from DOC and the research folks from DOH did was looking at the supervision data. And they started out with a very large sample size of over 9,000 folks, 9,000 unique individuals who had over 10,000 total supervision periods. So a very good sample size. What they then did was cull through that. And for the match, they narrowed it down to just those folks where there was complete data and folks who started supervision from FY 2014 to 2017. Wanted to get rid of the noise because there's always a lot of noise when you try to do these kinds of studies, right? Still ended up with a sample size of over 5,000 folks. Of those over 5,000 folks, 86% of them had some indication of a substance use or mental health need. 42% of the group had a mental health indicator. 78% had some indicator of a substance use issues. Those indicators came from the results of the risk and needs assessments, different diagnoses, programming assignments, and treatment participation, either while they were incarcerated or while they were under supervision in the community. Then took a look at the community-based mental health and substance use center data. This was a much larger N, not surprisingly, a much larger sample, over 66,000 unique individuals. Again, looked at folks from the same time period between 2014 and 2017, of folks who were receiving either outpatient or residential behavioral health, mental health, or substance use service. What that found was that there was an overlap of about 2,639 people, or about 52% of the supervision pool, and 9% of the clients attending the center. In other words, 52% of the people on supervision were accessing the centers. 9% of the clients who go to the centers are people who are on supervision. Now, get some caveats. The match only includes those folks who are on active parole or felony probation at the time. It did not include misdemeanor probation or people who might have historically been on supervision, but are not now, but are attending the center. And it was limited, obviously, to the availability of the identifying information to match the two sources, which is why we had to throw a number of individuals out of the sample. We can account for people accessing treatment services at the contracted programs, the 18 centers. There are no doubt some people accessing private services. As we look at that and we look at those numbers, those are fairly small numbers, but there's probably a few percent more than this that are accessing private treatment services because they have insurance or access to other types of care.
Senator Scott.
So it's 52% of the people that are on some kind of supervision, probation, parole.
Felony supervision, yes.
Okay, felony they are 52% need to access services, or 52% are accessing?
Have been seen by the
Marc.
center, or have been seen by a center, I should say.
Please proceed.
A couple of things to be clear. There needs to be some further analysis here. As I mentioned to you, this has been a lot of work done in a very short period of time. This analysis explores correlation. It doesn't explore causation. So we can show you these correlations between community mental health and substance use service provision. We can show you the cost of revocation to prison. We can show you a number of correlations. We cannot at this point show you causation. In order to do that, there needs to be some further analysis. There would need to be a randomized control trial to analyze the provision of the coordinated community health and substance use services to people that are high risk. Otherwise, we would not really be able to get to causation. We would certainly recommend that that be the next step in assessment as Wyoming moves forward. Now, even though 52% of folks on excuse me.
Welcome, Representative Clam. Glad you're here safely.
Yeah, thank you.
Please proceed.
Now, even though, as I mentioned, 52% of folks that there was a crossover in terms of the correlation, only slightly more than half of the people on supervision with a known need are actually accessing the services. There's some small variations depending on what risk level, et cetera, but generally speaking, only about half of the folks who should be accessing services are actually accessing those services. And sort of interesting thing, and when I say should, the should came from matching them with the mental health substance abuse indicator. So that's how we knew if they have that, they should be getting some type of intervention. Sort of an interesting thing, one issue, interesting and important, only about half of them are actually accessing. Another kind of interesting different point is that there's about 20% of those folks in supervision who don't have that flag, but who are actually accessing the services anyway. So that 52% includes a group of individuals that didn't have a flag, but clearly on their own determined they had some need, or when they got to probation or parole, there was a determination of a need, even if there wasn't a flag at that point, and they are accessing the centers for treatment. But when you put those numbers together, we have a lot of folks who are not accessing treatment, who clearly by assessment need that. When we look at the issue then of how quickly are people accessing, what we find is that in a lot of cases, not that quickly. When you look at these numbers here, if I can just sort of pull those up quickly, when you look at these numbers here, within a week, about 26% of folks do access. Within a month, another 19%, but a whopping 54% after a month. So for 54% of those people who are accessing, they're accessing well after a month. Why is this relevant? There are a number of reasons, and I'll talk about a couple of them in these next couple of slides, but let me just share with you some data from other states. What we have been able to show in other states is the longer it takes for someone with one of these needs to access that intervention, the greater the likelihood of them failing on supervision. So there's a clear direct correlation between the speed of accessing and whether or not they fail. We have not shown that yet directly here in Wyoming because we don't have those numbers. We have been able to show that in other states. There's no reason to believe that when we get to further analysis that that won't shake out in the same manner, because it has in state after state after state. So we look at that, and when you look at this across risk level, by the way, it's pretty much the same. In other words, whether people are high, moderate, or low, we're finding very similar rates of speed in terms of accessing centers. How does that connect to the issue of violations? The vast majority of parole and probation violations occur in the first year. In fact, virtually all of them occur within 5 years. So there's actually another discussion as to, is the expense of longer than 5 years of supervision worth it? Are you getting good cost benefit? But looking backwards to the first year and looking at these numbers and these charts, the majority of people are failing in the first year. This really does tie to that issue of access to services, because what we know again is that people don't necessarily get revoked after the first event, but after the second or the third or the fourth event. And so the faster we can get folks in services and the appropriate services, the greater we can lower the potential for revocation. And when I end this afternoon, in just a little while, I will show you about that in some other states. And I shared with all of you, in addition to the overheads that I'm presenting, I also shared with you a recent article from WildFile that talks about what North Dakota has done, which place that we have also done work in. And they've actually been doing this long enough along what I was just describing to you that they can show the initial drop in the revocations and the initial drop in their prison beds and prison bed use. So at your leisure later today, you could take a look at that article if you haven't seen it yet, and it will help further explain what it is that I'm quickly talking about. In conjunction with, again, our research team, folks with DOH did some statistic modeling, and they looked at matched data to show the benefits in terms of longer stays in the community and the cost savings associated with that among high-risk people. And what they did is they basically compared folks who accessed treatment and looked at potential outcome, folks that did not. And what they got in terms of an effect of this was basically when folks get what it is that when folks get what they should be getting, then there is a much greater likelihood of them remaining in the community. And with the statistical model, and the reason that I keep going back and forth is this is not a study of specific people. This is a model based on real people, but it is a model as opposed to real people that we can say Joe versus Jack. But comparing the two groups, what you find is that about 305 extra days in the community. That translates to 1, significant cost savings, and 2, in many cases, it translates to people actually reaching the end of their supervision period and no longer needing to be supervised, and whether they're incarcerated and cost savings there, or whether they are continuing to be supervised and the additional cost with that continued supervision. So sort of the key takeaways from this, again, in a very quick way, is that between 2014 and 2017, more than half of the folks on probation and parole supervision with an indicator of need, meaning mental health or substance use need, access mental health or substance addiction treatment in at least one of the community mental health and substance use centers. That the rates of folks on supervision with an indicator of need for treatment that access services vary across the state, and there's different rates. Rates as high as 66% and 80% in some districts, as low as 38% in other districts. So it varies depending on where we're looking at in the state. The targeting high-risk individuals with treatment services is associated with longer stays on supervision without a revocation, and likely positive net savings relative to the cost of prison days. And that mental health treatment, which is mostly delivered outpatient, is not surprisingly less expensive than mental health and substance addiction treatment that is provided, while in prison. Mental health treatment also, which is delivered outpatient, is less expensive than substance addiction treatment, but it has a weaker association with longer stays. To try to say that simply, what we know about mental health treatment is that it may make somebody in better shape to benefit from the other treatment, but the mental health treatment alone will not make it less likely they'll recidivate. And so mental health treatment is important, but by itself, it will not keep someone from committing a new crime. It may make them more knowledgeable about why they committed their new crime, but they will still commit that new crime if you don't provide these other types of intervention as well. So goals that we're suggesting in terms of enhancing the impact of treatment for folks on supervision with substance addiction and mental health or mental health treatment needs, connecting people on supervision with substance addiction or mental health needs to community treatment more swiftly, not in a week, not in a month, not in 3 months, in 48 hours, to really assure that that appointment is there prior to them leaving either court or the prison. To prioritize those folks who are at high risk to fail on supervision and also have a high need for treatment, and to tailor the strategies to the local areas around the state, because we know that the same needs aren't exactly the same depending on where you are in the state, to meet those specialized risk and needs of the population and the level of care that's available in the center. I'd like to wrap just with what happened last week in terms of Wyoming's justice reinvestment approach. Last week, on Friday, the Joint Judiciary Committee approved 5 bills comprising 3 strategies to increase public safety and avoid corrections costs. The first 2 bills focus probation and parole resources on programming on people who are at the greatest risk of failing on supervision. In other words, really directing it toward those people who scores high risk and high need on risk assessments. Secondly, to hold people on supervision accountable with swift, certain, and proportional sanctions. In other words, to have the availability for quick dips and to do so very quickly, sanction them when there's a problem, but also to have that time limited so that then you get back on supervision and you're not using unnecessary days in prison and adding to both the cost and the bed difficulties. And thirdly, to help victims receive coverage for expenses resulting from mental health services that they may need as a result of whatever crime that was inflicted upon them. Now, a bill was not raised in terms of behavioral health, but the Joint Judiciary Committee did explore the importance of addressing community mental health and substance addiction needs among probationers and parolees. They really looked at the issue of enhancing access to timely, specialized community treatment for people on supervision with substance addiction or mental health needs, and really talked about developing and providing the necessary intensity of specialized evidence-based community substance addiction and mental health treatment for people on probation and parole across Wyoming, improving care coordination, peer supports, and transportation planning to facilitate treatment that's tailored to the different regional needs across the state, because depending on where you are in the state, you don't have all of those same needs. Creating a more seamless continuity of care for folks that are coming out of prison. Again, that having that appointment within 48 hours, having that transition plan. Improving coordination between probation and parole field offices, community mental health and substance use centers by instituting coordinated collaborative case plans that are focused on behavioral change, meaning that that case plan is held between the people doing the treatment and the people doing supervision, as opposed to there being separate plans that never meet and that folks do not talk about at all. They explored how reducing recidivism by 25% could help avoid prison population growth and avoid significant costs. And so what they looked at was an impact analysis of the effect of reducing probation and parole revocation by up to 25% in order to reduce this. When you look at this, what they looked at was basically targeted 5% a year. So the goal is to reduce recidivism by 25%, to do it incrementally, 5% a year, starting in 2020 through 2024, ultimately resulting in that 25% reduction and a cost avoidance of $18.1 million. Because that's one of the main goals, obviously, in terms of looking at reinvestment and also looking at how to best spend what money there is to put out. If you avoid those costs by achieving the recidivism reduction goal, it would enable some reinvestment to strategies to increase public safety, some of the different components that we've been talking about. And you see in front of you 2 potential ways to look at it in terms of the potential averted costs, the net savings, and the reinvestment. And those are just 2 examples, 2 options for people to think about and to look at. The priority reinvestment areas would be increasing the admission of people on probation and parole to timely, specialized community mental health and substance addiction treatment, to improve recidivism reduction outcomes for people on intensive supervision and in the adult community correction centers by reinvestment in increased cognitive behavioral therapy and other evidence-based programming. Neighboring states have done these things. Neighboring states provide a variety of community behavioral health treatment targeting the probation and parole population. This has all happened in the last few years as part of their reinvestment work. In Idaho, they targeted $8.3 million for substance use disorder services for drug treatment, serving about 4,500 people who are on supervision annually. In Montana, they put about $7.5 million in community treatment facilities for people on supervision. In Utah, $5 million to expand community treatment access for folks in the justice system. And they also established standards based on evidence-based practices. And in Colorado, $9 million in correctional treatment, in the Correctional Treatment Cash Fund for the community supervision and other populations to offset their treatment costs. And of course, those states, as well as Wyoming, also have court-supervised treatment or drug courts in existence. Now, North Dakota, perhaps one of the closest examples in terms of facing some of the most similar issues. Their behavioral health strategy fosters a partnership between corrections and healthcare to prioritize the high-risk, high-need population, which is essentially what we're suggesting here, that collaboration between the Departments of Health and the Departments of Correction, and the collaboration between supervising agents and the treatment programs. They put $7 million out to improve healthcare outcomes and reduce recidivism by delivering high-quality community behavioral health services. And they did it in 3 areas. They looked at the establishment of behavioral health teams between corrections, health, probation, parole, and community care coordinating agencies. They looked at improving the specific quality type of services, and they looked at expanding the provider workforce because they have an issue similar to Wyoming in that even when they have money to provide a service in some areas, they don't have the workforce to be able to provide that service. Mr. Chairman, members of the committee, first of all, I thank you very much for the time to speak today. I have attempted to give you, frankly, a massive amount of information in a very short period of time, and I realize that, but we did the best that we could with the available time. Really hope that it has been helpful to you. If the bill drafts that the Joint Judiciary Committee voted unanimously to sponsor on Friday are enacted, it will actually help Wyoming reduce recidivism by 25%. And it will avoid $18 million in corrections costs over 5 years. That will indeed enable the state to reinvest starting next year in some proportion to enhance access to folks on probation and parole to timely specialized substance use and mental health services, and still have a net savings over what you would have been spending to build the additional prisons or contract the additional prison beds. And so we're certainly hopeful that that will occur. It's our considered recommendation that the state make those enhancements and really assure timely access to the appropriate treatment in centers across the state. I'm more than happy to take any additional questions. I know that I'm a bit over time, so I will stop here. I'm more than happy to take any additional questions or comments.
All right, questions. Senator Boner.
Thank you, Mr. Chairman. Just real quick, so I'm clear. You said that 18 million in savings. Is that an annual figure, or is that spread out over 5 years?
No, that is over 5 years.
Okay,
Further questions? Further questions? Because I'll do a couple of questions. So I've been following this with the work that the Judiciary Committee has been doing through the chairman mostly, but also through the minutes and the materials. When we talk about the five bills, was it that are coming forth, 4 or 5 bills that are coming out of that committee? Those are the cost savings you're talking about are net from them. We're not talking about what subsequent net we could get from actually implementing these reforms.
Is that correct?
Accurate?
That is correct.
Okay, so in these other states that you've done this, what would that double net be? I mean, what percentage greater improvement, whether you want to call it as far as more savings or less recidivism, what do you anticipate we could see?
See what you're saying. So part of it is where you start. If you're starting with keeping the population that you're already expecting to come up, not come up, then your net savings over those first 5 years are going to be limited to that. Assuming that that is effective in years 6, 7, and 8, you should see increased savings because you are now doing the same thing with the folks that you have on probation. In other words, now you've not only averted the new folks, but you're increasing the success with the people that would be on probation anyway or parole anyway, regardless. I could not give you a specific number in terms of that. That would require a whole lot of numbers crunching that I don't have access to the data of Wyoming to be able to do. I suspect it can be done, but it's not something that we have done.
Okay, in context to the North Dakota model, which there's a article out of one of the press article on that. When did they implement that, and how long has that been implemented?
North Dakota actually just started this last year. It was passed last year. It was put in place. The additional money has just started going out. It's fiscal year 2019, but the fiscal year 2019 started, and their initial data is already showing an impact. They don't know what the final impact will be, but there are some numbers in the article from WyoFile that show you the initial savings just several months into their project.
So I just want to be clear, and I saw the data in here, but I want to understand that they're just implementing it. This isn't just 1 year out of a series of years. This is the initial implementation.
This is the initial implementation of several months.
Okay, so I'll go back to the other states that have gone through this process with CSG years back. Pick a year: 2012, Hawaii, Oklahoma, Pennsylvania, Kansas, West Virginia, 2013. What kind of trends do they see?
Let me clarify. Every single state that we've ever done justice reinvestment in hasn't necessarily included a behavioral health component. And so in the states in 2012, behavioral health was not a central component, so I could not answer that. What I can tell you is that in the states, that's why the states that you see here for Idaho, Utah, Montana, and Colorado, that's why you're seeing things from 15, 17, 19, because the behavioral health focus is a relatively new component of justice reinvestment. Earlier, justice reinvestment was, how would I put this? Earlier justice reinvestment was focusing on other difficulties that existed in systems that could be quickly responded to. As those pieces were responded to, we began to look at more complicated and complex issues. And that's when we began to look at behavioral health. When you look at Idaho, Montana, Utah, and Colorado, I can tell you that every one of them has indeed seen an improvement as a result of what they've done. I cannot tell you off the top of my head the specific numbers because those were not my states, but we have that data and I can forward that to the committee.
Okay, thank you. Further questions? Start with Representative Sweeney.
Thank you, Mr. Chairman. In light of the Joint Judiciaries Committee approval of the 5 bills, was there any testimony? I'm assuming there's some new programming elements and additional need for whether it's mental health providers or within those bill drafts. Was there any testimony that we're in need of licensed professionals to fulfill these programs?
Go ahead, please.
I will, let me answer that in 2 ways. The first answer is I could not tell you because I was not the staff member who was there, though some in the audience were. So I could not tell you if there was testimony. I can tell you, however, in our analysis of what is occurring in the state, that there is a workforce shortage in areas of your state, and there is a need to think about how to increase the workforce to be able to provide the necessary services.
Thank you. Further questions? Chairman Scott.
Mr. Chairman, I've been trying to think of what I've just heard, and it takes a little time to process some of it. It seems to me what I hear you telling us is great payoffs to having this intervention in the behavioral health, the mental health, and the substance abuse areas. And I'm hearing 3 components to it. One is just mechanical, things like getting somebody an appointment before you release them so that the contact is made swiftly and surely. Second is just plain having enough money in the substance abuse and the mental health systems so they can accommodate this demand, and they're not accommodating a little under half of it. So the money aspect is real important here.
Yes, sir.
And then the third item is this, that Representative Sweeney was just raising, making sure we have enough qualified professionals so that they're available. Even if the money's available, we can get them. So, and I don't have any sense of the relative importance of those three aspects. I take it they're all critical.
Go ahead, Mr. DeMora.
I'm actually going to give you a fourth aspect. And the fourth aspect is not just having people having access to the services in a timely fashion, but assuring that the correct services are available. And that is a function of two things, a function of the money for services and a function of having the people to provide the services. So I'm just putting a finer point on that item because I think it's important. It is a wonderful chicken and egg question, isn't it? If I were to try to rank order them, number one is getting people immediate access to services, and 1.5 is everything else. It's not a 1, 2, 3, 4.
Thank you. Further questions? Further questions in this presentation? And then I'll just ask you to stay there and we'll ask for comments from the public. Comments. All right. Yes, Senator.
Thank you, Mr. Chairman. I just was curious if there were fiscal notes attached to these bills from judiciary. I mean, is anybody from maybe our committee or somebody that's been tracking those bills?
So we have some folks from the Department of Corrections who have been involved in those discussions with Judiciary Committee, and certainly Mr. Director, Deputy Director, if either one of you want to address Senator Peterson's question about fiscal notes associated or fiscal costs associated with the bills that are coming out of Judiciary. Director, please introduce yourself.
Mr. Chairman, members of the committee, Bob Lampert, Director of the Department of Corrections. There's not fiscal notes attached at this time.
Okay. Thank
Well,
you.
just to follow, my concern is these are great ideas and great concepts, and I think this committee has studied this. I'm glad Judiciary's caught up with this committee on our belief that this is important, but if there's no money attributed or allocated for these services to be enhanced, I don't see these services going much anywhere. I mean, there's got to be some money. I mean, we've gutted mental health over the years to the point where now we're expecting to do some more with the same amount. So I'm assuming that there's probably going to be some fiscal notes attached as this progresses on.
Director.
Mr. Chairman, it's our anticipation that there will be some fiscal notes. However, and I would defer to Mr. Lindley to see if he has a number in mind, but from our previous request, there is some replication of request, which I believe is in $5 million range.
Okay, thank you. He just came up with that off the top of his head in the back second row. Could have went for 7. We wouldn't have known the difference. All right. Thank you. Does anybody have, since the director's up, does anybody have questions for the director while he's at the stand? Questions from the committee? Representative Sweeney.
Mr. Chairman, thank you. Director, through the chair, were you there during testimony as far as the five new bills at Judiciary?
Director, please.
Mr. Chairman, I was there and I did testify.
If I could have a follow-up, Mr. Chair. So in that testimony with the programming and that's contained within the bills, was there additional need for licensed professionals within the context of any of that testimony?
Go ahead, Director Lampert.
Mr. Chairman, I don't recall it being a specific topic. However, there was mention of a need to look at how to increase the number of licensed substance abuse treatment providers in the state and alternatives to that, including peer specialists.
All right. Thank you.
Thank
Further
you.
questions for the director? Further question? Thank you, Director Lampert.
Thank you.
Anyone else like to testify? Boy, we don't get chairs and chiefs here very often, but go ahead. Mr. Odikoven, glad to have you here.
Thank you, Mr. Chairman. Byron Odikoven, representing the Wyoming Association of Sheriffs and Chiefs of Police, and thank you to the committee for taking up this topic. I appreciate the fact that you are looking at the other half, if you will. The sheriffs and chiefs have voiced concern for a number of years on early intervention, proper treatment, proper options for treatment to provide success for those folks, either one, who are first entered the system not staying long in the system, or two, not coming back to the system upon initial entry. We've worked with the Council of State Governments rather well over the course of this interview, if you will, of the state of Wyoming and the data solicitation. We've worked on mining data from the jail perspective and trying to correlate, and it's been fascinating looking at some of that data that we've espoused over the course of time, saying we need more treatment if we're going to have less people in jail. And if we had more people treated, they wouldn't be coming back to jail. So I'm glad that the data is pointing that out, and I welcome this discussion to help further that along, because we can't arrest our way out of the program or problem, but we might be able to treat our way to a lesser incarceration of the problem folks, our opinion. A couple of points. There was a question and two rather anecdotal that we've offered to assist CSG with doing some further data mining. Several of the courts track their people coming before them for alcohol and substance abuse issues, maybe not for why they're in court, but whether or not the person has an alcohol and substance abuse issue. And I believe the data out of two of the communities that we looked at, Gillette and Natrona County, nearly 87% of the people who were appearing in court admitted to or were found to have an underlying alcohol or substance abuse issue. That may not be why they were actually there for an assault, there for a burglary, there for a whatever, but they did admit and or were found to have that underlying issue. This companion question in those two jails again was that over half of the people in jail incarcerated on any given day were on psychotropics. Whether they were on prescription psychotropics prior to the admission of jail or determined while in jail for a longer period of time as part of a medical screening to be in need of psychotropics and thus further treatment. Over half of those folks. So yes, that fits within the general number of some of the data mining that came out of the need for that substance abuse and mental health treatment. An interesting point, and I saw some eyebrows raised earlier when we talked about drug possession and drug delivery and drug misdemeanor offenses going up significantly, and they have. The next slide, the point that was made, or that was not made as much, is for those people, if you look at on the bottom after slide 15, slide 16, the middle of the column, it points out over that same 4-year period that drug offenses for those people who actually end up going to prison, a 3% increase. So while there's a 107% increase in felony possession cases and a 41% increase in misdemeanor cases, only 3% of the folks find their way to jail. So I think part of what that says is the criminal justice system is doing everything they can to keep from throwing those people in jail until they run out of options and they put them in jail 3% of the time. Now, having said that, when they come back through or they do their technical violation, which I love the term technical violation. So I have a hot UA 8 times in a row, and I finally declare that's a technical violation. I was stoned too many times, and now I get to go to jail. So again, many of those technical violations point to the need for that substance abuse, mental health treatment timely to the community so they don't end up in jail. So we welcome the discussion. Love to have the further payment or further budget to do proper treatment. It's pay now, pay later. Do nothing, we'll build the beds. We're still going to arrest them. It's still a crime. As we talked about the companion pieces and the bills that were last Thursday and Friday, and looking at supervision, there's still a whole block of people, if the one bill passes, who won't be supervised in year 4 and 5, basically. Looking at probably 11 or 12% of them that'll recidivate or find a new crime. They won't be revoked while on probation or parole. they'll end up being charged with a new crime, new investigation, new trial, new pre-sentence investigation, and a new round of services, I'm guessing. But so there is a cost benefit. There is a Chicken Little, or chicken and egg, I should say. And I'm hoping that we can find that balance to provide that proper treatment. As we also talked in judiciary, these people are the neighbors. These people are the people at the grocery store before they went out on whatever night of the week they did to do whatever they did. They're the folks you saw yesterday before they made the paper today. They're in the community. It's people that we need to deal with at the community level in proper treatment, intervention, supervision to ensure that they lead a law-abiding life and the public safety is preserved. Mr. Chairman.
Thank you, Byron. Do we have any questions? Representative Sweeney.
Thank you, Mr. Chairman. You referenced slide 16. Could you back up to 15? And I would just ask your opinion in mining data. Back to my question in reference to these numbers to marijuana, full-blown recreational legalization in Colorado, specifically to the numbers on misdemeanor and felony.
Mr. Odikoven.
Do you believe there's a correlation?
Mr. Odikoven.
Thank you, Mr. Chairman, and I'll take an opportunity to go a little longer than the normal. Yes. There's a
Thank you.
correlation.
Oh, you're going to go longer?
Sorry, I am, Mr. Chairman. Yes.
That was good.
Our general belief, anecdotally, is our surrounding states who have chosen to legalize some of those endeavors and the advertising that we have now before us is creating that sympathetic view toward that. But I think the criminal justice system has responded in the manner that you have a number of offenses, you have a number of arrests, but they aren't going to the pen. So we're doing something different with them, if you will. Having said that, today's marijuana issues aren't yesterday's issues. Today, with a gummy bear that's advertised to be sliced into 37 slices because of the potency factor, is a little unrealistic to imagine that somebody, and actually you can go online and look at the advertisements. The 10% coupon was last weekend, I might add, if for the purchase of those 37 slice gummy bears, which is fascinating how that goes around, or the different infused products that are designed to imitate other products, again, to create that attitude toward, it's okay. One person at the table can have a Pop-Tart and the other one can have a Pop-Tart, kind of a thing. Breakfast for diversity kind of discussion is something that we're not used to seeing or used to having to deal with. But yeah, so I think substance abuse, what it does point to is substance abuse issues, and those underlying issues to criminal behavior is very real based on some of the other states' actions and events. Yes, sir, Mr. Chairman.
Okay, thank you. Further questions from Mr. Odikoven? Further questions? Thank you very much. Appreciate your time.
Mr. Chairman.
Anyone else want to speak to this topic? Go ahead, Paul.
Mr. Chairman, members of the committee, my name is Paul Demple. I'm the CEO of Northern Wyoming Mental Health Center, as well as a member of WAMSAC. And the chart you saw earlier with all the green dots all over the state, covering the state with outpatient and residential mental health and substance abuse services, that's us. And I don't really have any comment other than to say we're here. We're already involved with this population. We absolutely see the need to provide more treatment, to have more connection between the Department of Corrections and the Department of Health, so we can work together. We're already doing that in a lot of idiosyncratic ways, in various ways, where we're meeting with probation officers monthly in various ways in various places. But there really is no system to approach that. And with CSG's efforts here, I think I see a way forward for a system. The only thing I would caution would be, as we're moving forward for this system, that I think it's critical for WAMSAC to be at the table with the development of the plan, that if the Department of Health and the Department of Corrections get together and then hand down a plan, that's not going to be nearly as effective as if WAMSAC is at the table in the development of the plan, because we're the ones on the ground floor that are doing these things. So we look forward to helping out whatever way we can. We're actually very excited about the data that CSG has, and we're prepared to step in whatever way we can to help improve this problem.
All right. Thank you, Paul. Any questions for Paul? Mr. Demple, any questions? Thank you very much. Thank you for being here. Anyone else? Go ahead. Mr. Lindley, come on up.
Thank you, Mr. Chairman. Steve Lindley with the Department of Corrections. So consistent with Mr. Demple's comments and, of course, the presentation from Mr. DeMora. I guess what we're asking the committee, and whether it would be in the form of an informal endorsement or some more formal action, is we really need, and to Senator Peterson's comment, the figure I threw out is related to on the fiscal note, some of the items that are in the just passed legislation from judiciary, and doesn't address the issue we're talking about here today with the behavioral health piece in the community. There's other elements of that in the other legislation. What we really need to try and determine, and we can do it on our own without the committee's direction, certainly with WAMSAC and the Department of Health and the Department of Corrections, do an analysis of why 50% of the people that need treatment, substance abuse and mental health treatment, aren't accessing it. It'll be a combination of things, I think: availability, transportation, the Addicted Severity Index, which assesses substance abuse and is used uniformly across the state. Some centers require there are time frames as far as how old they can be. But even when some are more current, offenders are being required to have them redone, pay cash, $150 to $200, which they don't have. And so there are a variety of hurdles to getting why half of that group isn't accessing the treatment. And so when we talk about the potential of a 25% reduction, it's slightly confusing. Maybe that's in revocation rate. Numerically, to put it into context, 1,000 people basically are coming into the prison system in Wyoming each year. Half of them are for probation and parole violations, most of which are drug related. And so and to Senator Scott's point earlier, the reduction of substance abuse treatment services in prison as a result of the budget issues involve both residential beds and all intensive outpatient in prison, which the money's now been restored. We're ramping that back up. We continue to have issues finding staff, or our providers do, which is another hurdle. But we've seen in the last 3 years the recidivism rate, where Wyoming had the second best out of the Pew study of 2010 at 24%. We're now up 31%. So that correlation between treatment going down, recidivism rate going up, while we haven't studied it for causation, we're pretty confident it's related to that. So what needs to happen here to make this entire package work is for us to get this behavioral health piece better reviewed, to be able to come back then and say, here are the gaps. North Dakota had one model, which seems like there's some potential there, using peer specialists, care coordinators, lay people helping to fill in some of those gaps as one response in conjunction with the treatment that the WAMSAC providers bring. So anyway, I guess we're asking for the committee to decide what you think might be the best so with different changes in committee assignments here shortly, kind of through judiciary and all of that, as well as different people involved. We'd like to maintain the momentum. And however this committee thinks we can do that to do this next phase on the behavioral health part, we would appreciate.
Okay. Questions, Senator Scott?
Chairman, responding to that, I think the whole mental health system is going to be part of this committee's charge going forward. It is now, and I think will be probably in the next interim as well, and should be. And we've got a number of problems and a number of needs, and I think this has been very useful in terms of educating us on an important piece of work that our centers, community mental health and substance abuse centers, are doing and need to continue to do and enhance. I think it will inform things we do even in this meeting on availability of the personnel, making sure we can get the people in here to do the treatment. I think it'll inform what we do in terms of trying to figure out how the heck we're going to finance what's needed. We need to understand the full range. So I do think that sounds to me like the immediate thing is to support the Judiciary Committee bills that are making sense, but that's only the start. And we've got to deal with the system such that it's capable of adequately responding. And I will say parenthetically, Mr. Chairman, that having just listened to a bunch of other states and their mental health difficulties, we've sure got some difficulties. We've all been wrestling with the Title 25 and some of the other issues, but I'd much rather have our set of difficulties than what I heard about from a bunch of the other states just recently, Mr. Chairman.
Thank you, Senator Scott. Any further questions for Deputy Director Lindley? Yep, I'm sorry. Representative Halverson.
Thank you, Mr. Chairman. Deputy Director, this is the first I'm hearing about a role that lay people can play in all this. Would you give us 1 minute on where lay people would fit into the process?
Director.
Mr. Chairman,
Deputy Director.
Representative Halverson and Mr. DeMora is more qualified to speak to it.
Would you
Speak to
pull
it
that
and-
mic closer or pull it
Move up.
one or the other, please?
And maybe the use of the term lay people isn't exactly correct. However, peer specialists and care coordinators and their fit into the treatment system helps fill some of the gaps that therapists aren't able to fill, either through availability, principally, or location, which I guess is another version of availability. And I don't know, Mr. DeMora, if you could
Go ahead, Mr. DeMora.
heighten that response.
Certainly, excuse me, certainly, Mr. Chairman and Representative Halverson. In addition to that, peer specialists can be very helpful in terms of ongoing support between sessions. They can be very helpful in terms of assuring that people, or helping assure that people are able to get to their sessions, whether that's through simply developing relationships with them so that that's part of what they do together in terms of have those discussions, when is your next appointment, or in some cases, whether or not they even are able to provide transportation or other supports in order to get them there, so that peer supports do not replace the clinicians, but they're able to do a whole lot of things to support clinicians, and in a number of cases can also provide services to individuals who may have already received some services but need some ongoing aftercare support, and can be helpful in that manner as well.
Thank you very much. Further questions for the director?
Mr. Chairman.
Representative Sweeney.
Follow up on funding, and I would direct this to you as far as being within the Department of Corrections on part of this. Is Medicaid at all in play as far as reimbursement on part of this?
Deputy Director Lindley.
Chairman, Representative Sweeney, the short and quick answer is not to any extent at all. With Wyoming not expanding Medicaid, that limited much of it in that regard. 2 years ago, the Management Council, there was a scoping paper done on that issue, which I'm sure LSO could provide as far as availability both of Medicare and Medicaid. But it's limited, I think it would be the answer, limited to close to non-existent, I think.
Okay, thank you. Representative Clem.
Thank you, Mr. Chairman. Deputy Director is, I'm trying to, came in midway through here, so I'm just trying to wrap my head around what we're trying to do here. So what I understand is that by providing some of these services for mental health and substance abuse for those who need it coming out of prison, who are on parole, that we could actually, instead of reincarceration again, costing more money, that we could save some money by getting them help. I guess what I'm trying to figure is that, okay, I'm seeing a nod ahead. I think we're on the same page there. What I'm trying to get at is, and I think the committee is too, it is going to cost some money up front as far as whether it's $5 million or something. And I'm trying to just play it practically, how this is going to play out. Person comes out of prison, they get an appointment right away, maybe with the mental health center. They don't have Medicaid or private insurance because they just came out of prison. So what do they have? And I think that's where that block of money comes in. Someone's going to have to pay for it, at least initially. And I imagine that it's going to come from the reinvestment of money that could be saved later on. I guess the key issue is how much money are we talking? If we were to put all this together, I mean, what kind of money would we be saving that we could reinvest? Is it $5 million or is it something else, or do we need more study on that?
Mr. Chairman.
Right.
Representative Clem and again, Mr. DeMora can reiterate part of his presentation, but in short summary, over the next 5 years, with the previously referenced 25% reduction on people returning for violating their probation and parole, it could equal about $18 million over that 4 to 5 year period. The one example, so this is the 4th year for the judiciary that this has been an interim topic. Last year in drafted legislation, one piece that I thought held much promise was a 6-month treatment program under the authority of the Department of Corrections, available to the courts for probationers to send a violating probationer to treatment for 6 months. The court retains jurisdiction. That's not normally the case when they send somebody to prison, with a couple of exceptions. And then upon completion, the person goes back to the community and continues on probation under the authority of the court. To serve about 180 violating probationers a year, and the price tag for that, I think, was $3.5 million for the biennium. And that's in large part why it didn't go forward. So that gives, I guess, a little more context to cost. There, the discussion was kind of on your point. In other words, the committee appropriations was saying, well, if you're saving money somewhere, put it toward this, but it wasn't, that money wasn't available right at that point. And by CSG's estimations of this money saved over time, then it begins to build on itself, and eventually you would need to be reinvesting less than you needed, actually. I mean, you'd be saving more than you needed to reinvest.
All right.
Mr. Chairman, Representative
DeMora,
Clem, when you have an opportunity, slide 45 would also give you an example of some of the savings and the 2 potential options about reinvestment in terms of amount of reinvestment.
thank you. Representative Hallinan.
Thank you, Mr. Chairman. I served on the Opioid Addiction Task Force, and on that committee, I thought that that the Department of Corrections is providing medically associated treatment for the opioid addiction. patients. And I asked a member from the Department of Health, and she said that after a person is released from prison, that the Department of Health is going to provide the medically associated treatment for drug addiction for opiates for a period of time. I thought it was for maybe 3 or 6 months. Is that something that you're familiar with, sir?
Mr. Lindley.
Mr. Chairman and Representative Hallinan, there are the division administrators from the Department of Health are here and could speak to that more fully. To your first point, the Department of Corrections has not in prison participated yet in a medication-assisted treatment or MAT approach, though Department of Health has just received a significant opioid grant that Department of Corrections is part of or had an element of. And so we may be moving in that direction. As far as they have, and again, both Chris Newman or Carol Day can speak to it more fully than I can. Prior to the most recent grant award, there was a 3-year, I think it was in Sweetwater County and Natrona County, pilot where probation and parole offenders, and I'm sure others, those are the ones I knew of, were involved in medication-assisted treatment in the community. And that grant has run its course. A new one has been received and is more extensive than the previous one. So those elements that you reference now are being reformulated and revised and ready to be implemented.
Thank you. For Senator Peterson.
Just briefly, Mr. Chairman, thank you. Considering the strategy behind these bills that the judiciary is bringing forward, and as we talk about the finances of the fiscal note, I'm wondering, and this question is probably for WAMSAC, for the Department of Health, Department of Corrections, all the players involved, is if we could attach an accurate fiscal note of what resources are needed that we don't have presently to get us there, or if the strategy is to introduce the bills without a fiscal note or without an accurate fiscal note. And then a year from now, come back with saying, you know, this is the money we need to implement this great concept of this idea. And I can certainly echo Co-Chairman Scott's suggestion that this committee get behind these 4 bills at the judiciary. I mean, this committee's been convinced of this cost savings for a long time and have been touting that effort and those facts. And so I'm glad judiciary's stepping up with these bills, but the finances is still a concern for me, the fiscal note. So I'm wondering, my question is if such a meeting is necessary to attach an accurate fiscal note to these 4 bills, could that be put together between now and January or before the session starts? And it would have to be consultation with WAMSAC to see what, and maybe the answer is, you know, we've got the resources necessary, but I doubt that. I think they're probably going to look at you and say, yeah, we need 1 more staff person in each one of these centers or something like that. And that's going to mean money. So I'm wondering if there's a chance that that meeting could be held, if that's the strategy to put an accurate fiscal note to these bills. And if that's not the strategy, if the strategy is to introduce the bills without a fiscal note and then just kind of go with it for another year and then come back and beg for money later, and that might be the strategy, I don't know. But so what's the strategy? And if it is the strategy to attach a fiscal note, an accurate fiscal note, can that meeting be held before the session begins?
Mr. Chairman and Senator Peterson, we haven't been asked for a fiscal note yet, and Mr. Racinas is in the back who helps oversee that committee for LSO and may be procedurally able to answer that. Through this process over the last 3 to 4 years, it has happened a couple of different ways, and last year was a different way where it was actually in the bill, an amount, and then other times we get pre-filed bills and we're asked to do fiscal notes. Neither the chairman of judiciary, and this just happened last Friday, has asked us yet to do a fiscal note. I guess we were, and if Director Lampert has other information, I guess I was anticipating that that would happen somewhere between the introduction and referral to committee and then referral back to appropriations, and it would be going on then. It clearly isn't in the current governor's budget, and so, which was part of the problem on the previous one. So again, we've not been asked to provide one, and all of the discussion just happened last Friday on the third and final interim meeting. So either Mr. Racinas or possibly Director Lampert, that's, at least in my mind, when it will have to take place is sometime after the start of the session. If we're allowed to do one prior, either on our own initiative, I've not done one on our, where that was my idea. We'll certainly follow what we're asked to do. We haven't been asked, though we would. It clearly needs the appropriation.
All right. Any final questions? Final questions? Anyone else want? Thank you, Deputy Director. Anyone else want to testify to this bill? Or did Mr. Racinas want to respond to anything on the fiscal note or anything in that regard? Oh, I didn't see. Sorry. Director Lambert, go ahead.
Mr. Chairman, members of the committee, Bob Lampert, Director of the Department of Corrections. I just wanted to clarify one thing, that the $5 million that we put forward is what we anticipate would be the cost of the bills as drafted. It does not address the issues of any subsequent investment for study or for community-based treatment. So the fiscal note that we would provide, if requested to do so, as Deputy Director Lindley indicated, would be to address the additional sanctions and treatment that are included in the existing legislation. Now, Mr. Lindley also indicated that we ran into a bit of a snag previously with some legislation that did not have an appropriations clause in the bill, and it got kicked back to us. However, in this particular instance, LSO is the one who drafted the legislation, not the Department of Corrections. So our previous error is not something that I'm comfortable telling LSO how to do their job. But it is certainly a conversation that we can have to ensure that we have the information available to the committee as they move forward, and LSO can work with the committee to ensure that it's included should it be necessary.
Okay, thank you.
Thank you.
Anyone further? Anyone further? Anyone new that wants to testify to the committee? Go ahead, Mr. Odekoven. Please proceed.
Thank you, Mr. Chairman. Byron Odekoven again for the Wyoming Sheriffs and Chiefs, specifically the Bill Draft 230. The committee, we voiced, there's several pieces to the bill that involves incarceration and treatment that takes place in the county jail at a 90-day amount, which is more than has been previously discussed. And our comment to the judiciary at that point was, please get it properly funded, and that will be a fine thing to do. Without proper funding, there's no way to do it. So there is some significant fiscal work that needs to be accomplished with those two specific pieces. And then a third new piece they added was at the current rate of incarceration, its anticipation of how that plays, if you will. By statute, the Department of Corrections is limited to a $65 a day payment to the counties to do that, because the days that they're talking about are the days that the judge says you're guilty and you're going to the pen and the pen picks you up. There's a period of time in there where that is anticipated to cover, not at a rate of 90 days at a time, so to speak. So there's a third provision they added, that there would be a negotiated rate of incarceration. Many of the jails' incarceration rate for dollars is over $100 a day. So there is some significant fiscal work that needs to be done with 230 to find its success. We support that successful outcome for many of the reasons we've already voiced here yet today, just reinforcing that there is some fiscal work that needs to be done, Mr. Chairman.
Okay. Thank you. Anyone else in the audience want to speak to this topic? Anyone else in the audience want to speak to this topic? Very well. Thank you, Mr. DeMora. Appreciate
again,
it. You
Mr.
want any
Chairman.
final comments?
Excuse me. I want to once again, Mr. Chairman, and to everyone here, say thank you, because as I'm listening to all of you, I'm sort of listening to folks who clearly are sort of passionate, if you will, about getting this right. And it is a significant issue. When I look at the data, if you get this right, the improvement for the people of Wyoming will be significant. And so will the cost savings. But first and foremost, the improvement for the people of Wyoming will be significant. And I think that is a sort of wonderful potential outcome. So thank you very much for the time today and for listening to our data, and hope that we can be helpful again in the future.
Thank you very much. So for the committees, their work continues in supporting through the Judiciary Committee in this process through the legislative session, and then I think a little bit beyond that. So there is more work that they will be providing, and you'll see them probably in other venues. Mr. Marc Pelka is actually the lead on the program in Wyoming. So thank you very much. I don't know that there's any, we're not going to take any action on this committee, but it was really brought to give us a heads up of some of the things that are going to be discussed in our next session, by both in the virtue of bills and then potentially in the context of a supplemental budget request or letters from the governor, or certainly in the next interim. This committee, I would anticipate, may have a topic assigned to it along these lines. So, any final comments from the committee on this? Final comments. All right. So what I'd like to do now, we're only 41 minutes behind, but we're going to go ahead and go. Mr. Nicholas is here to discuss the organ donation report and give him adequate time, and then we're going to take a break after his, and we'll come back for our final topic of the day. I will mention to folks, there are some folks that want to give some public comment based on some of the topics we've already heard today at the end of our day. So I'll just throw that out there. So welcome.
Distributed to you already, or it's really page? I don't know.
I think we did get, I did get it when it was submitted, but I don't know about the rest of the committee. We'll share for now, so don't worry about the copies.
Fine, it's not that complicated.
So glad to have you here.
Mr. Chairman, glad to be here. Thank you very much. I apologize, co-chair of the committees, for not having a tie on. I just came out 11. I had some dental work done, and they were actually complaining that I had a white shirt on, so I'm halfway there, but the tie got lost. Thank you for having me here. Mr. Chairman, with respect to the work of the volunteer committee, what we discovered in looking at the issues of organ donation, we identified 10 areas of things that would deserve interim work next year, or only about 3 or 4 would require any type of legislation. Mr. Chairman, the committee actually met once. We collected a bunch of data, met once, and then I think we'll have one more phone call just to ask people for their suggestions with respect to how to move forward. But in general, what we discovered, Mr. Chairman, is that the organ donation task force, or not task force, but the organ procurement entities that are operated in Utah and in Denver really have great resources available to us. And they have great ideas. And I think if we simply implement many of the ideas that they're proposing, or have a vehicle for them to have access to promote some of their ideas, that's about all we really need to do. And as I take you through this list, I think you'll find pretty quickly that what we're talking about is how to enlarge the number of donors that are registered throughout Wyoming. There are various ways to do that. In general, what we learned is that right now there's 2 vehicles to become a donor in Wyoming. One is on your license plate, or license application, you do the check. That gets you on that list. That only gets you there for 4 years, for the length of your license. And so when you get renewed, If you don't check again, then you fall off the list. So it's not a lifetime registration. It's each time you go through the license process. So states are trying to improve the number of donors that sign up, but that's the primary purpose of the Donor Alliance in Denver, and they're assigned to our territory to implement these areas. So what you're going to see is that most of these ideas that have been promoted are how to improve the number of, or make it easier for people to register. It's assumed that if you don't want to register, you won't. But if you do want to register and you want to be a donor, then it's simply trying to make that an easier process. You may recall we talked that Alaska has the highest number of registrations in the United States. It's up in the 90%. But turned out it's, when we looked into it, it's pretty easy. When they send out their capita checks and you get your $4,000, you get to sign up. And I think people really feel good when they get those checks and they all sign up. So you bet you can have my organ. I'm okay with it. Just keep sending the money. So what do we talk about? Let me take you through the list that you have in front of me. And I apologize for having a couple short, but the YDOT license procedures. This is something I think we can just work with. The Donor Alliance can work with the state of Wyoming, but it is it's how to make sure that people are advised and reminded during the renewal process. So there's a lot of education directed at young students, young drivers before they first go in and do that registration. But there's an opportunity to do better, provide better information to the to people when they renew their license, because you have to recheck that. One of the things that Colorado discovered is that in Colorado they've implemented a process where the driver's examiners actually ask the question of, would you like to be a donor? And they find that if the question is asked by a person, the registration is higher. But to do that and to accommodate that, in Colorado, they have an electronic system where you go in and you sign up and you do all of your registration electronically. And then the examiner has your application and they essentially turn a monitor around and they ask you the question, and that involves in the answer, checking the box. The examiner will do that. Wyoming has not yet arrived there. They are working on a program where in the next few years they'll be having electronic applications. Right now, you're still at the form, but this is a topic that I think it's just a matter of continuing to work with YDOT as they implement it. The next issue of outreach and training is it's pretty self-explanatory, and that is investing training opportunities with EMTs throughout Wyoming, investigate training opportunities with the community colleges and with the legal and estate plan community organization. And I really think there's not a lot to be done other than keeping a group together in Wyoming that would work with Donor Alliance to give them access to the folks and to these areas. I think part of the problem, frankly, is that Donor Alliance is in Denver and they just don't have fingers into Wyoming. So they simply need volunteers to help them do it. But it's a topic area that was addressed. The coroner standards, you recall that we spoke about that during the last legislative session. The recommendation is that the Donor Alliance simply meet with the Board of Coroner Standards to adopt post-training standards on their own, implementing the Uniform Anatomical Gift Act and solid organ and eye tissue donation. And we had a member of the coroners on the committee, and it's really believed that they'll do that voluntarily, and it's just a matter of education. One of the topic areas, number 4, is hunting and fishing licenses. That's what you have is the PowerPoint presentation that was provided by the state of Minnesota. Minnesota has been the first to implement registration when you sign on or when you acquire your licenses, your either fishing license or hunting license. It was well received in Minnesota. And again, it's just one more time where this group of people are, as you know, are signing up annually. And it turns out it's a community that has been very receptive to that, and it's done a great deal to lift their registrations numbers by about 10%. The Donor Alliance met with the Game and Fish Commission, I think just last week. I spoke with one of the commissioners today. He said it was well received. They think that they can immediately at least put a link on to go to the website to register. And they can be again doing that immediately, but to actually provide the mechanism where you actually check and get onto the list, that would require legislation. And so I think we will come back with a recommendation and ask you to at least look at that during interim study next year. We think it's not a time-intensive issue, but we do think it'd be well received. And we also think, as I pointed out, that this is a community that generally does have high percentage of donations or registrations for donations. Public outreach, this is again, the Donor Alliance would like better access to the school districts, and we've agreed to assist with them to introduce them to the Wyoming Department of Education and take a look at the training. We think that there's more that can be done. That's simply pursuing that effort and giving them in-state help. Fundraising for education, number 6. Frankly, there's a lot of resources out there that the state of Wyoming has not been utilizing, and there are resources that are earmarked to be deployed in Wyoming, but there's simply not been a relationship where Donor Alliance can better implement it. So we need to take advantage of that, and we will. With respect to the opportunities, one of the areas that Donor Alliance would like to investigate was the use of or offering license stickers that you would put onto your license plate as a donation. And in fact, frankly, it may be that they want to simply offer that for anybody that signs up, and you would not pay anything. So they'll work with YDOT with respect to those opportunities. We discourage them from driver's license or driver's license plates or new plates, and rather just looked at this as, yeah. Well, I understand. And so we, YDOT suggested that making a sticker that's for the Donor Alliance would be much easier. And it may be that's one of those things where it becomes just a gift to those people that are, and encouragement to put them on their license plates if they're signing up just for that. Override issues, legislation. This is one that we may come back, and I don't know that we'd be able to have legislation proposed for you, but we may want you to ask to look at that interim study. The issue there is that in the event that right now the decision to release a body for transplantation, you'll recall this is the issue where you have a death that occurs, the body's on life support, but there may be criminal activity involved. And we had the instance where a young child was not released last summer. That's a horrible situation because young children are rarely, those organs rarely become available, and those are organs where you can actually say that if you lose a child or that opportunity to gift, 8 little children are going to die down in Denver. It's just going to happen. So the issue is whether or not if in those areas where there is an inability of the county attorney or the coroner to make a decision whether there ought to be an override capacity at the Attorney General's office, we think that'd be a good idea. We have not met with the Attorney General yet. We intend to do that. So before making that recommendation as interim study, we'd like to converse with them. Carryover, yes. The last item, number 8. Now these are by the way, put in priority items. So 8 and 9 are the least priorities, and you'll get a sense of why we programmed them last. Carryover, yes, is the issue of whether or not some states have embarked in legislation that says once you check the box the first time, you're on the registration forever until you withdraw yourself. So as I explained, when you get your license, you check the box, but you have to renew that every 4 years to stay on the list. The issue is whether or not, well, if you are willing to put it, become a donor at the beginning and you check the box, should you stay on the registration for the rest of your life unless you ask to be removed? I think we sort of felt that about that the same way we felt about compelling people, or sort of the opt-in, opt-out discussion. You'll recall that. And our general view is it's the task of the Donor Alliance to encourage people to renew. And if you don't renew, it's presumed that you didn't want to. And so that was put on last, where we make no recommendation. In fact, the Donor Alliance recommends that not be adopted and that process not be followed. They just don't think it's a healthy environment to encourage donation. The state of Georgia offers a $1 discount to your driver's license application if you'll sign up. It's sort of a bribe to be a donor, and we put that very last. My general view is just we set our fees at what we expect everybody to pay, and that's just it. The idea of giving a discount to sign up, just don't think I think it falls in that same category that we just described. And so those are left as last. Future work, we do think there's a place for an advisory board that would meet only once a year, just to provide help to the Donor Alliance in Wyoming to make sure they're reaching. Mr. Chairman, I think that there are the areas that that would warrant legislation is the hunting and fishing license issue, and the override legislation. And my recommendation is, with your willingness, is to propose that as your interim topics. I think it would be more easily implemented through interim. I don't think it'll take you very much time. I think it's about the amount of time we're commanding right now. And I think but I do think with the hunter's license, I think is a great idea. But I think it's not something that should be implemented or can be proposed to be implemented without public hearing. And the committee work that we did, the volunteer work, simply doesn't provide that vehicle. So I think it would have to come back to an interim committee so they would have public hearing and go forward. The override issue with respect to the Attorney General, maybe that could be proposed as legislation, but we've not met with them, and so we're making no recommendation yet. If we don't come up with a solution between now and the time that you finish up this session, we can talk about whether it ought to be interim. Mr. Chairman, if you'd accept that as our report, that's really it. We will meet one more time by phone just to talk about these final areas and recommendations. And with respect to the advisory council that would be permanent, that would meet once a year, we'll talk to you more about that before session, and maybe offer that as either interim topic or as a piece of legislation before session. But that's generally what the work encompassed.
Thank you very much, and thank you for the work for all those that participated. I know there was timing got a little short in the late go.
Yeah, we were late getting started. Actually, it's wonderful to get out and have a career outside the legislation, but it turns out the work comes first. Those pesky people called clients.
All right. Thank you very much. Any questions for Mr. Nicholas? Question? Yes, sir. Senator Peterson.
Thank you, Mr. Chairman. Phil, do you have, speaking of that number 8 carryover, do you have the numbers of those?
We don't have the numbers. I don't think it's well tracked. And the way you would look at the number is say, well, if you're at 85%, can you get up to 87 or 88%? Frankly, Wyoming is among the highest, so we stand in a pretty good position. So my personal opinion, Senator, is that it's not very high, and it certainly wouldn't mean, when you're at 86%, why would you tell people, hey, you're on forever? So I just don't think it's warranted, but we don't know what that is. And when you begin to compare yourselves to these other states, until you see the aberration, which is Alaska, and with the per capita payments, everyone else, we rank pretty high. And so you're only talking a couple percent.
Well, Mr. Chairman, yeah, thank you. The reason I asked that is I think most people would be surprised if they didn't think that was a for life. They'd be surprised if they have to renew that every 4 years, is what I'm saying. And
well, I think that's true. And what you're going to see in this is the, I'm not sure if it's true. I accept it as true, but I think, frankly, the flip side is true, that people that check it once just get in the routine of checking it. But it does require continuous education, so people understand that they have to continue to do the exercise over and over.
Thank you. Representative Clem.
Thank you, Mr. Chairman. Phil, on the hunting license deal, how do they deal with the discrepancy? For instance, if someone has put that they are an organ donor on their license, and then yet on their hunting license they check no, or vice versa.
Well, there's no check. You never check no. You only check on. So you would once you check on, you go into the list for that period of time. So you get added to the list. If you're already on the list for other reasons, you don't get added twice. So there has to be a list that's maintained. And it should not be the cost of the anglers and the hunters to maintain the list. That's part of Donor Alliance and the federal funds that they get to receive those. But so you can get online and revoke it, if you will, but you wouldn't revoke it in the hunting license. You would only add in, and then if you had forgotten to do it on your driver's license, then you go on. Now the experiment or the implementation in Minnesota suggested that they moved their percentages like 2 or 3%. So that would suggest about 3% of their population were hunters and anglers who, when added, were new time ads, which is kind of interesting. That's the driver's license. Maybe they didn't realize they had to do it every year. So about 2 to 3%. And those are big numbers for the organ donation community.
Senator Bouchard.
Thank you, Mr. Chairman. I just thought of some things talking about having public comment and everything. That stuff was kind of already done on driver's licenses. And I don't think there's a hesitation from the public on something like this. And I think the only thing I would like to see is something like a data repository where not personal data, but how many yeses we get, how many no's we get, or how many check-ons. Mm-hmm. But I'm also willing to do a private bill, and maybe I could find someone else in here that would do it, and we move it forward and see.
Well, I appreciate that.
Mr. Nicholas, go ahead.
I'm kind of interested how people feel. What I don't want to do is push the bill more quickly and risk that it would die, and the community of that are really involved and at stake in this get upset. I mean, I'm easier to slow it up for a year. If the Game and Fish can implement by just putting the link on their website, but it would be an easy bill to draft and to get there if we believe that it would be well received. But if they need to be prepared, if interim treatment improves the odds, I think I'd recommend that they slow down. So, I am interested in what your thoughts are.
Chairman Scott.
Mr. Chairman, on that point, I would sure encourage members of the committee that this would be a good opportunity, particularly the Game and Fish one here, for a private bill. We're concerned in general that we're getting too many interim bills, and the interim committee is not having the time to work some of its key bills well enough as a general rule in the legislature. So we're wanting to encourage private bills, and this looks to me like one that's ideally meant for a private bill. It means you got to do some digging work with the Game and Fish, see what they really need, see how they think it might really work, all the things you got to do to prepare a bill properly. But you would make a good general session bill. This committee is obviously not going to have such a bill for the general session, since this is our last meeting. So, Mr. Chairman, I would sure encourage Senator Bouchard and anybody else that's interested in it, get together and see if you can come up with something that would be a private bill this time.
Sure, I think it's easy. We'll just go to Minnesota and take their template and circulate it and see if people like the way it's drafted. Easy to do.
Further questions for Mr. Nicholas? Further questions? All right. We thank you very much for your
Thank
work.
you very much for the opportunity. And I know if the Donor Alliance, Sue Dunn was traveling today. If she was here, I'm sure she'd be grateful that the legislature is looking into these issues and giving them assistance. And that's really what we're doing, is helping them.
Appreciate that.
Thank you very much.
I would make a comment to the committee, being that one is a fishing licensing bill. It may not come to this committee, and the other is a judiciary issue for the AG. It may not come to this committee.
Sure,
So.
understood. But, I think
Anyway.
this is the committee that really understands the implications.
Thank you very much.
Thank you.
Appreciate it.
Thank you.
Have a good day.
Appreciate it.
All right, committee, let's take with all due respect to the optometrists and ophthalmologists and all the interested public, we're going to take a break until 1:15, and then we'll resume our deliberations. Thank you.
one or two here. The next topic for us is the Optometrist Practice Act amendment, the various versions of that bill. What I'm going to do is they're all very similar. There are some small differences. Will work just as a matter of convenience from the 04 version. And Chairman Barlow will take us through that. Then we'll ask for, after we've heard questions and gone through that, we'll ask for public comment. If those don't fully explain what the differences are between the versions, and I suspect they will, because I think advocates will point out that we ought to bring this over from this other bill. Then we'll ask for a clarification of what the differences are, and then we'll be open to amendments. So, Chairman Barlow, if you will lead off, and is it all right with you if we ask questions, if members have them as you go through the bill?
Chairman Scott, certainly.
Okay, proceed.
All right. Thank you, members of the committee. So out of the last meeting that we had, version 0.2 was the version that came out of that meeting, and we tabled it, we forwarded it to this meeting for consideration. And so out of that meeting, as you recall, there were numerous types of public comments. And so what I did was I went and I took all the different things that I heard and a few things that maybe weren't proposals, but I had in my mind that I would like to see in a final draft bill. And I created version 0.4. Now, 0.3 is the intersection of those two. So you can see both current language and my proposed things. You can see how they interplay. But I want to be clear that my intent, with the exception of two components, was to only maybe reorganize the draft that was before us at our last meeting and clarify and actually compartmentalize the things. As you recall in our last meeting, there were basically three things: basic optometry, the prescriptive authority issue, and the surgery, the advanced procedures authority. And so there was in the bill draft, which is 0.2, there was they were kind of mashed into one big paragraph, and they were pretty. It was pretty hard to kind of dissect them out. So my effort was, in substance, was to pull them apart, so that what you got is basic, and then prescriptive, and then surgical, and we wouldn't be monkeying with one while we're trying to work on another. And I think that's my attempt. Now, there's two additional things, and these came from one from me and one in visiting with the board after our meeting, the optometry board, the regulatory body. One is adding 2 members to that board. If you'll recall, there were 3 members on that board currently. They're all optometrists. So I added 2 more members, a general public and a healthcare professional. And then there's another one, we'll go through it. So with that, I just want to be clear. I didn't try to change the intent of what our bill is before us. I just tried to streamline it and then make it a little more compartmentalized. So if we started down the amending route, it would be fairly precise, or we could be more concise in what we were trying to impact. So if you will, I'll just quickly go through the bill. And obviously blue is the blue strike language is current statute. And then we get into the new language. So I'll just start on page 3. And to be clear, these are amendments that I asked to be drafted and placed into bill form. So these are not what the bill you saw in the last meeting. These are mine.
Mr. Chairman, are we doing 0.2?
0.4.
0.4 is the bill draft that I'm going to work through.
And let me ask clarification on that. You said they're yours. Are these just items that were in the other bill and you've reorganized them so that we can work with them more readily?
Mr. Chairman, yes. And I'll point out there's a few that weren't in the previous bill, one being that board issue, but these are, so page 3, this is basically a reorganization, if you will, breaking up that big paragraph that we had in version 2, and you can look at it, it's in version 2. There's a great big paragraph, and what this did is just break it out and kind of give you five different components that were under was called primary human eye care procedures. So this is kind of the basics. Now you'll see that, and this is, and I took out a lot of language. I took out zero and plano lenses because actually if you go back to the definition of contact lenses, it includes those. So you didn't need some of that language in my view in this bill. So it was just my effort to try to kind of line out what we're talking about. And these were all things, and the optometrists have reviewed this bill. They've had this and they've looked at it, and at least their indication to me so far has been they're in agreement. This captured everything they intended to adequately, and hopefully is understandable. I will say that in this, and on page 3, when you go down to line 18, this refers to the prescribing authority, and of course that's referenced in another part of this bill. And so if we adjust that, you don't have to touch this unless, of course, we strike that entire part out or don't give them any prescriptive authority. But we don't have to do anything with this if we go into that other section. The next one, the C, which is line 21 on page 3, into the top of page 4, lines through 5. This is the advanced optometric procedures, which included surgical, etc. And the one thing that I added into their bill draft that they did not have was the, on line 2, 3, and 4, this rulemaking authority to actually identify what those procedures were, and training requirements, reporting requirements, and anything that else is deemed necessary. Because as you recall, in our last meeting, this is an addition, or this is allowing optometrists to do things that currently they are prohibited from doing. They believe it is within their scope of practice, and they believe that they are trained to do it. But we also heard from folks that said, no, not so fast. So what this is kind of giving a check, because if you go to D, and this is exactly verbatim out of the previous bill, the point 2 draft from our last meeting. These are the things that they're not allowed to do. So we had a list of things that we're not allowed to do, but we didn't have a mechanism to say what is actually appropriate. And I felt like going the board route and the board having to specify what is appropriate, what is within the scope of practice, and what training is required to do that seemed to be at least my attempt at getting to a middle point, saying we know we're not going to allow these things. What is appropriate? Well, if we don't actually have a mechanism to say what's appropriate, i.e. through some kind of a process, we're going to have disagreements as we go. So allowing the board the authority to lay that out made sense to me. So that is one addition that I added to this bill, this component of rulemaking to actually say what you can do and under what circumstances, etc. Obviously, the bill already contained what you couldn't do. Now, it's up to other people to let us know whether that D, Part D, which starts on page 4, line 7, is adequate, if there's enough in it, if there's enough, that's complete. My point was, if it's incomplete, then this one above can cover that, because we're not going to get everything there. But the board can say, nope, not so fast. We're not really trained to do that. Hold back. And I think, like I said, that was my attempt at a check and balance. Those things, obviously, the things you can't do go through the top of page 6. Or let's say the bottom of page 6. So those are all the things that are not in the scope of practice for optometrists. The top of page 7, E. If you'll recall, this was language, or similar language was in the previous, in point 2, and it basically said you can give shots in an emergency. I think they used the word inoculations in that draft, and I just felt that was kind of a term that was at least odd in my view. And so what I asked LSO to do is just find some more consistent language was elsewhere used in statute, and this is what they came up with. So this just allows in a public health emergency basically to administer immunizations. So that it's a little different language, but the intent was the same. Obviously some room numbering, and then you get to page 9. This is...
Chairman, any questions so far? I would ask one question on this immunizations language. Suppose you have to do something with an antibiotic put it in your terms, to the whole herd, to whole population in some area because of exposure to some disease in a crisis. Would this cover that?
Mr. Chairman, I guess I'm not going to speak for the state health officer who was here. But I would respectfully say that immunization is different than a antibiotic. Immunization is trying to stimulate immune response, whether it's a bacterial or a viral response, and an antibiotic is actually trying to treat that. So I think this is specific to creating immunity in the human body, not treating a disease process that's already underway. Immunization is about stimulating immune response. It is not about treatment. Now, that doesn't mean that part of herd immunity, if you will, to use a more veterinary term, herd immunity isn't important, but it's really a preventive model, not a treatment model.
Okay, proceed.
Thank you, Mr. Chairman. Apparently, the state health officer isn't here because I didn't feel any daggers on the back of my neck. So this gets to page 9. And this was the prescriptive authority, and I did in the previous draft there was a little bit of different language. It had timelines for they could prescribe for 5 days and different things, and I just tried to simplify that. And I did it in the context of what the opioid task force was already working on, and we have several bills that we've already advanced. We'll have another one we consider tomorrow that deals with prescribing opioid prescribing authorities. So I didn't want to compound that issue within the context of this, and just keep this to whether they have prescriptive authority, not all the details of that prescriptive authority. The rest of this, I think, is relatively not trying to get. I'm not trying to change anything. I'm just trying to clean it up and make it read appropriately. You will notice that there is the addition of prescribe. I think dispense is the added word, or maybe it's prescribe and dispense. Anyway, I did add this prescribe or dispense. I think it's dispense actually, because that way they would actually be able to provide a sample even to someone who was in their office and walked out. Because as in previous draft, they would say, we want to be able to give out samples because they get samples as people come in. Well, that's actually a dispensing action. We better give them authority to do it if we're going to allow, if we're going to say they're allowed to. So, that is a change in this. And if I'm missing something, I'm sure folks will point it out as I come back, as they come up. Next, page 10. This is a change that I brought forth, is the changing of the board, the State Board of Examiners for optometry, in optometry, excuse me. I added 2 members, a general public and a healthcare professional, and that was the only change except for the striking of the old language, which was in the previous bill. And the consideration there is 1 to 3-member board is a fairly small board, just in context. And somebody will be able to tell you how many practicing optometrists are in the state, but I think we're in the several hundred, I believe, if I recall correctly, licensed optometrists. And I just felt like most other boards that we have some public or other entity individuals represented on them. And I just felt like that was an appropriate thing to do, not bringing up the North Carolina cases as well. Next, page 11 is straight out the previous bill. Page 12, actually, there's some language that was brought back in that was stricken out of the last one, and that had to do with the education components. Certainly the optometrists or the board can speak to that. And then the language in the bottom of 12, this kind of goes back to that advanced procedures thing. If we need to ask for more licensure, they can do that. More requirements, they can do that by rule. I think everything on 13 is from the previous bill. 14, there was also language that was stricken in the first bill that's come back in, and this has to do on line 6 through 14. This is language that allowed them to offer CE with funds that they received from their licensure fees. So that would help facilitate keeping folks licensed within the state of Wyoming, and gave them some latitude to use those fees for that. If you strike this, then they don't have that latitude. So this was actually requested to come back into the bill from the previous draft. So, Mr. Chairman, I think that is the full, at least my brief explanation of the amendments that I did within the context of this bill, and I'd certainly stand for any questions from the committee.
Committee, any questions?
Hey, Mr. Chair, just briefly, and I apologize if I missed it, but what are the repealers?
Mr. Chairman, if I could, the 1117 is the volunteer license, volunteer optometry license. And there's a section in the Optometry Act that allows optometrists to volunteer. But as you recall, we did the volunteer healthcare provider last year. So this component was actually could be stricken. In the previous draft, it was stricken all but the last section. And the last section we decided wasn't relevant either. So we struck the whole section out. To B and D, those were both stricken out of the previous draft. And I apologize. We'll have to get the optometrists to correct that. I was just trying to go over what I was familiar had been done. So I apologize. I can't speak to those individually.
Anybody else? Senator Peterson.
Thank you, Mr. Chairman. Representative Barlow, it's an opportunity. We've got some new committee members that are going to be taking on this committee here next year, and they're probably asking the same question I am of, again, remind us of why we're doing this. And after I looked down this list of surgical approvals, my question is why don't we just eliminate the practice of optometry in Wyoming and just make them all ophthalmologists? And I that's a serious question, because these are things that, and I guess it's up to the patient to trust enough in an optometrist to go into the knife and have his eye operated on by an optometrist. My concerns are just immense with this bill.
Okay, Mr. Chairman. So I guess I'm not clear. The list of procedures that is listed in the bill under that section D, subsection D, are items that are not within the scope of practice for an optometrist. So D are things that they are not allowed to do. So in fact, by virtue of that, those would be procedures that would be reserved to an ophthalmologist, an MD ophthalmologist. Now, there are procedures, and we had this discussion in our first meeting about what's in and what's out. And so these are out of the scope of practice. At least that's my understanding of the intent and the way the bill is drafted. What we didn't, so do you have a corresponding list that says these things are in? And our current, the draft that was before us last meeting kind of left it like that, ambiguous. And what I tried to do with my board interaction was say, I think it's probably appropriate for the board to actually outline what is appropriate within the context of the scope of practice of optometry. We've already said these things are off the table, i.e. left to ophthalmologists. Now, what is appropriate for the optometrist? So I guess I still think that there is a distinction. I think this bill, whether you agree with the bill or the context of it or the list, I can't speak to that, but I think that we are still keeping very separate, or there is the opportunity to keep separate scopes of practice. Identify what's not in the scope of practice, procedure-wise. Is it exhaustive? I don't know, but the fail-safe is the board, the way at least I've proposed it be drafted, we can take it from a may to a shall if we choose to, and that would make it even more definitive, dispositive, that they would have to consider those things. But that's a whole nother public process, rulemaking, that they would go through to make those determinations. So what is within the context of their practice, scope of practice, and the training requirements that would be requisite to do those procedures. So I don't know if that speaks to your concern, but I think it does actually separate it and make it more clear that there is two professions here, one with the complete scope of practice and one with a defined scope of practice. Thank you, Mr. Chairman.
Thank you, Mr. Chairman. Just a quick follow-up then. And then getting back to the reason why we're looking at this is the demand or the request, does it come from the optometrists? Is this a national push? Other states have done this, and so we're looking at it. Where was the directive? I mean, give me a percentage of the number of optometrists requiring that these changes be made. Was it 25%, 50%, 70%, 100%? Do all optometrists agree with this?
Mr. Chairman, so I guess what I'm going to prefer to do is leave that to the Optometrists Association, to the Board of Optometry, et cetera. My only effort in this bill draft and my amendments to the bill draft was to make it, at least from my perspective, to clean it up, to add a little more nuance to the types of procedures, and to go out for a couple of issues. My effort was not to sell this bill. My effort was to hopefully improve this bill so that we would have a product that we could, one, work more easily, and two, defend more readily based on checks and balances within it. So I apologize. I'm not going to defend the need. I think I was convinced that there was need to have a discussion. The committee as a whole will decide whether we advance it or not. So thank you, Mr. Chairman.
Mr. Chairman, just quickly, I appreciate that. I just wanted an update on some of these members that are here that weren't there in Casper when we discussed this, and I just wanted to refresh everybody's memory on this bill and why we're looking at it and what we're trying to do.
And Mr. Chairman, to be clear, this was an interim topic assigned by Management Council from interest generated during the last session and assigned to this committee. We had two, physical therapists and optometry. We already passed out the physical therapy bill, and now we're on our final meeting, second last day on optometry. Thank you, Mr. Chairman.
And I would add to what Mr. Co-Chairman said. One of the things we did here, and I've heard it privately a number of times, is that we're having trouble recruiting these professionals, and that having a scope of practice that restricts what the younger ones can do that are coming out of training. They're trained to do things and then they aren't legally allowed to here. That makes it hard to recruit. And I can tell you from my personal experience, we are short of both ophthalmologists and optometrists. And it's difficult to get a timely appointment with them. So I think that problem is very real. So that's another factor that's in play in this bill. Representative Clem, do you have a question?
Yeah, Mr. Chairman, thank you. Chairman Barlow, on page 10, when you talk about expanding the board to 5 members, I guess what I'm trying to figure out is what is the definition of an allied healthcare professional? Is that defined somewhere else in the statute? Or I think I know what that means, but I just not sure what allied healthcare professional is.
Mr. Chairman, and fair question. That was actually language. I told the advocates for this bill that I was going to do something along those lines, and I said, if you have some language, suggest it. I think there actually is probably a better term of art than allied healthcare professional. Allied, would indicate if you're a doctor, a nurse, but I don't know what the allied component is to optometrists. So you could be more broad and just say licensed healthcare provider or something like that. That would open it up to anyone licensed in the state of Wyoming. So I'm not saying this is the perfect language, but I was trying to get out the point. We were looking, they were willing, and I am interested in having another healthcare provider on the board so that you have at least some familiarity with healthcare. Mr. Chairman.
Follow up.
Yeah, and following up on that, the general meaning of an allied healthcare profession is a healthcare profession that's not a medical doctor or a dentist.
So, Mr. Chairman, I guess what I was trying to, in my mind, I think it goes to maybe an ophthalmologist. Is that? I guess what I'm trying to figure out is, are you thinking anybody within the healthcare community could qualify as a member of this board, or are you looking at maybe a particular profession such as an ophthalmologist who would be that allied member on the board?
Mr. Chairman, I guess the intent that I have is that it's much far broader than a single profession. And one of the reasons is I think if you put an there's only so many ophthalmologists in the state of Wyoming. And so I think you have to be a little broader with just getting someone on there that maybe an advanced practice registered nurse or whoever that would be willing to serve on the board. So it is broader than that specific intent. Thank you.
Representative Halverson.
Thank you, Mr. Chairman. Chairman Barlow, I think you've done a great job here, and I think you consolidated all that was important and actually alleviated a lot of concerns that some people had. On page 9, under the prescribing authority, approved pharmaceutical agents on line 13. I'm looking at this chart that we received at either our last meeting or the meeting before that. Does that include oral steroids, oral antifungal medications, oral immunosuppressives, and injectable authority? These are all the things that currently they are prohibited from doing. So is it your intention that all of these be included in the prescribing authority?
Mr. Chairman, so I did not, the bill draft that we reviewed in Casper did all of those things. I changed none of those things. So they are still allowing for oral, injectable, immunosuppressives, et cetera. And the language is actually on that page 9. You will see on line 15, you'll see the excluding, and then you'll see the strikeout. We're still leaving in the Schedule 1 and 2, but we're, just like in the previous draft, we're allowing for that hydrocodone component. The previous one had the limitations on 5 days and all that. I just took that out for there because I think there's a better, more appropriate place to put that. But yes, I did not change any of that. That came out of the last one. That is consistent with what the request was the last time, I believe. Thank you, Mr. Chairman.
Representative McGuire.
Thank you, Mr. Chairman. Mr. Chairman, I appreciate the fact that you have reshuffled the deck, and I just want to ask you a question, make sure that I have the correct understanding. So I am starting with page number 12, and I'm looking at from line 9 down, where originally an optometrist would have gone to a school. It would be an accredited school, have taken a test. And so let's use, for example, an individual who went to school maybe 20 years ago. And so I understand what happened at that point. Now, when I turn back to page number 4, at the top, the top paragraph, lines 1 through 5. So let's say that that individual has been in practice and has come back and wants to now exercise privileges which involve surgery. Is there anything in this bill draft that assures the consumer that that training has been either accredited or approved outside of just the board members of Wyoming? And by that, I'm looking at, it's not, you know, a class that was put together and is not accepted anywhere else. I'm just wondering what would be the assurance to the consumer that the individual who is going to perform surgery is doing so to the same licensure requirements that other professionals in the state are subject to.
Mr. Chairman. So page 12, the language that's in or out of there was not language that I made a recommendation to change. This was items that the association and that the board wanted to adjust. So I will let them speak to those concerns. I was willing to include it in my adjustments, but I can't speak to the standards that you're talking about, because this is language that they felt was appropriate, both some additions and some subtractions within this section. As far as the language back on page 4, that is language that I brought in. Now, we can be more specific and more clarifying, and we can actually make it a requirement that they adopt rules and but I also included, as you will see from that, the training requirements. What is appropriate? If we want to make it further than just training, we want to say the accreditation of the training requirements or the accredited training requirements. That's completely appropriate. I was trying to, but this component right here was not. I mean, this wasn't something I felt was a high priority. This was a priority for the board or the association, not for me. The other component is, if it needs to be further fleshed out, I'm certainly open to that.
Thank you, Mr. Chairman. I just wanted to make sure I wasn't missing it somewhere else. So that answers my question. Thank you.
Yeah.
Representative Clem.
Thank you, Mr. Chairman. Representative Barlow, on page 12, I think help me walk through this a little bit, because I think there's a serious ramification here. If you look here on page 12, line 15, it says clearly, examinations shall cover subjects designated by the board. On line 3, the crossed out language says required to pass the examination series administered by the board. So what we're doing is striking out that language, and we're saying on line 6, an examination. So my understanding right now is there's a series of examinations administered by the board, but the new language simply says an examination that shall cover subjects included in the practice of optometry. I think that's a pretty substantial change. And I didn't know if that was something, am I missing that, or am I wrong, or is that something that possibly we need to look at some more?
Mr. Chairman, thank you. Again, this is language that came straight from out of this last meeting. So this is language that if questions about examination versus examinations, national boards, and that's for, I would respectfully say, that's for the proponents to make their case on. I'm not, I guess I was not intending to, my effort was not to adjust everything they did, was just to adjust the sections I thought we could do a better job with. The rest of it is their language. This comes out of the last draft, and I would respectfully say that others should address that. Thank you, Mr. Chairman.
And I would add to that, you look at a number of other licensure acts. This is not an unusual procedure to let the board specify that. And we've tended to loosen them up because sometimes you get, there was an accepted way of doing things, and then the profession moved elsewhere, and we get caught with our language being just plain obsolete. And so this is not, I don't think, if you look in the other licensure statutes, this kind of flexibility for the board is not unusual. Okay, any further questions? Let me ask one, and it's back on page 4, where the board's going to specify authorized procedures, etc. Is there, thinking of the interplay with any prohibition section, is there an opportunity for the board to put members of the general public that are doing certain things in this area out of business by specifying, no, that's now part of the practice of optometry, so if you're not an optometrist, you can't do it? Do we have that risk present with this language?
Mr. Chairman, I guess if someone holds himself, I mean, that goes to other parts of current statute. If someone holds himself out as an optometrist and is doing procedures that they're clearly not trained for, I think that there's still authority for the board to have an injunction. Now, I don't know about the opposite, i.e., are we going to restrict someone that is doing something that is outside the practice of optometry from doing what they shouldn't be doing anyway? I don't know what that procedure would be, I guess is my point. I don't know what we're talking about that they would say now is in practice optometry that has not been. So I guess I'd defer to the board or someone else for that question, because I'm just not sure what that would be.
And Mr. Chairman, I don't think this is one we've got to resolve today, but I think we're going to need to look very carefully on the final bill of the interplay with the existing statute. because we have seen across the country boards get in trouble that way. The prime example being the North Carolina Dentist Board that tried to say that only dentists could do tooth whitening, and resulted in that Supreme Court case. We don't want to get into that kind of trouble. I'm just wondering, is there an unintended interplay?
Mr. Chairman, all I can say is this: if they wanted to do that, they have to go through a rulemaking process, and hopefully through that process, those things would come to light.
Anybody else? Okay, proceed. Anything further?
Nothing further, Mr. Chairman.
Okay.
Move the bill.
Mr. Chairman, one last
Okay.
thing, if I may.
Under Peterson.
Thank you, Mr. Chairman. So getting back to my original comment, at the bottom of page 3, it talks about this, except as otherwise provided by subsection D of this section, a person holding a license to practice optometry under this act is authorized to perform surgical and other, turn the page, advanced optometric procedures upon the human eye. And then it gives us a long list of things that they can't do surgically. So getting back to the bottom of 3, what's performing surgical? What's that referring to? I mean, what kind of surgery can they do? And where is it in the list that they can? Right now, it seems a little open-ended, leaving it according to their training and the board to approve or disapprove, so that word surgical, and then it just kind of leaves it open, and then it gives us a long list of things they can't do surgically. So what's that perform surgical? What's that referring to? What can they do?
Mr. Chairman, so I'll go back to a statement I've made a couple times. I guess I have no. I mean, we can certainly engage this as a committee. This is the request that was before us. This is the bill that's before us from the last one. I'm not going to defend the proponents of the bill on their behalf. They can do that for themselves. What I tried to do is make things compartmentalized. So if you don't like section C and D, you wipe them out and you don't jeopardize section A and B. So that's what my effort was to do, was to make things so they're segmented, because previous to that, A had surgical in it and D had surgical in it. And we were going to start getting into so if you're concerned about the scope of the surgical or those type of issues, then it's more, I would argue, the way this is currently drafted, you don't like it, strike C and D, and that question is done. That's what my effort was try to do this. Now, I obviously went a little further, and I tried to put some sideboards on what a surgical procedure is, but by requiring the rulemaking. But it's pretty tough to have an inclusive and an exclusive list in the bill and have them to be appropriately exhaustive. We decided at our first meeting, what my recollection is, we decided to go with the exclude list. These are things you can't do. And then at the last meeting, we heard, well, the comment you just made is, well, we're not sure what you can do. What I tried to come up with is a mechanism so there is a way to identify what is possible, and that is through the board process. The legislature wants to get into that game. We're going to be here a long time. Okay. Thank you, Mr. Chairman.
Thank you.
Following up on that, I would say when the optometrists come up, if you guys could answer that question. There is a restriction in here, and you can see it on page 4, line 1. It's procedures upon the human eye and the tissue around it, is how I read that. So, it isn't authorizing them to take your appendix out or anything like that. That's pretty clear here. What I would ask them is to tell us, given that language and this exclusion list, what's left that you will be allowed to do in answer to that last question. What I want to do next, seeing we've exhausted the questions and the chairman, is that we'll have the optometrists come up and explain why they want the bill. Do they want anything changed here? Answer that question and any others they think need answering. Then I'm going to ask for the medical society to come up and say their piece. And then we'll go to any kind of any further public testimony before we come back and move the bill and work it. Okay, with that, optometrists, you're on. And if one of you could introduce the whole group, it would be helpful.
Mr. Chairman, members, excuse me, members of the committee. My name is Catherine Wilkinson, representing the Wyoming Optometric Association. I have here with me Carrie Klein, who is the Executive Director of the Wyoming Optometric Association, Dr. Dana Day, who is an optometrist in Casper, and Dr. Jeremy Nett, who is an optometrist here in Cheyenne. Mr. Chairman, members of the committee, just for a very brief overview, again, the reason for bringing this bill forward is to allow optometrists to practice within the scope of the education that they are currently receiving. It is our hope that the licensed optometrists here would be able to utilize those skills that are being taught and also retain those students who are receiving that education and come back to the state and then are not able to practice to that full extent. Mr. Chairman, would you like us to go through and address some of the questions first?
Either proceed however you want to. That would be fine if you want to do it that way.
Mr. Chairman, let me go back through some of the questions really quickly. First, if I may, as to the other repealers that were in the bill, B was the percentages that were required on the examinations before. Do you have anything else to add? And then D. Oh, I'm sorry. This was of the old working draft from the last committee meeting. So it's version 1, 0.1. That's on page 16. So that was D. So those were the percentages that were required for the examinations for B. And then for D, it was the fees for the licensees, and then how they had to renew their license with the board. And if they failed to do it, that they wouldn't be reinstated. It was just outlining specific license requirements. To address the allied healthcare professional, I believe that the Board of Examiners in Optometry is here and they do have a proposed amendment as to that language. I'll let them do that, but I believe it's specifically to add the word license to ensure that it is a healthcare provider. We have the same understanding as Senator Scott, as that it is generally someone in that healthcare profession, but I do know there is an amendment forthcoming with that. As to the accreditation with the school, I know that there is also another amendment with the board. Once again, that goes to the fact that we are asking for this bill to come forward after 25 years. And if standards change and they do decide to move to another testing agency, that it would be appropriate. There, you are correct that there is a series of examinations, and it is the intent, I think, of the board. Again, I'll let them speak to that, but to keep that standard testing in there. So if that needs to be amended to add an S to examinations, we certainly would have no problem with that. In terms of the accreditation in association with the continuing education, did you want to answer that on the CE? Okay.
Chairman Scott, Carrie Klein with the Wyoming Optometric Association. Why am I even here today, right? No, just kidding. Representative McGuire, I think the second half of your question dealt with how we would assure the public that optometrists who've been practicing for a number of years going back to receive specific new continuing education to become licensed or have the ability to do the new procedures. And I believe the board is prepared to outline what procedure they would be taking to ensure that those optometrists are going through a series of tests, licensure, what they will have to provide to the board to then be able to do that.
Okay. And you got further?
Chairman Scott, Dana Day, optometrist from Casper. I think there was one other question that came up from Senator Peterson concerning what can you do? Again, as we've testified previously, you get into that debate of inclusionary, exclusionary. The difficulty you have with inclusionary list is every time new technology comes out, well, we'll be here every year in order to come and ask you for, okay, now we're trained on this, can we please do that? And you're going to have I think you're going to find that technology advances much faster and you can advance bills. When we do the exclusionary list, like you voted on and decided, was that really puts those guardrails in place, and it specifies, as Representative Barlow was indicating, that you then have that separation between the two entities, the two professions that you were concerned about. Obviously, there is a difference in the background of education. And so that's why you have an ophthalmologist that does the invasive surgery. When we're talking about advanced procedures, we're talking about procedures that are not getting into the eye with a scalpel. That, we're not talking about removing the eye. We're not talking about retina surgery. Again, that's why that's on the exclusionary list. We're talking about more simple things like lumps and bumps removal, removing what's called a granuloma, again, foreign body removal, lash appellation, punctal occlusion. These are still things that are, when you look at insurance codes, those codes get defined as a surgery code. Well, okay, so when we have again, we're talking about the training that we've received, and the students are getting this training coming out of school with that training, and then we're sitting in a state where we haven't updated this in 25 years. Well, that's why we're asking for that update in order to now be practicing to, again, the best of our education ability, but not going beyond that. We're not seeking to go beyond what that education is. And we're following the same medical model that other professions do. When they have a scope defined and they go back and they get continuing education year after year, that's why we have that in place, so that we provide the best possible care to our patients and are up to date with the technology. But as that technology changes, and a new procedure comes out, again, you look at any medical profession, a new procedure comes out on how to take a kidney out, for example. Well, that doctor's got to go back and be certified on that. They've got to receive that education and receive that certification. And so that's what that's all about. And we're following that same process. So I hope that kind of answers that question.
Peters. Thank you, Mr. Chairman. And along those lines, so as I get down to that bottom of page 3 again, perform surgical and other, is there a better term that could better define the type of surgery we're talking about? I mean, I know it's invasive surgery when you cut around the tissue of the eye. I mean, so I'm just trying to, I'm not a professional surgeon or a medical background at all. I'm just trying to figure out, is there a better term to use besides just surgical?
Chairman Scott, Senator Peterson. I'm not sure if I have a great answer for that. I guess ultimately, if the committee has extreme heartburn with the word surgery, we can stick with the terminology advanced optometric procedures, which would work fine, and we still have that exclusionary list that we're not going to touch those other items. And the advanced optometric procedures then are going to be defined by the rulemaking of the board, and that's actually what's done now. We have a certain scope of practice currently. Well, who decides what we can do? The rulemaking process with our current board. They're the ones that say, okay, within your scope, you can do this now, provided you have that education. So that, again, like I say, if the word surgery becomes a real heartburn for the committee, I think as an optometric profession, we're fine with you keeping the word advanced optometric procedure within there. But I think you're kind of talking the same thing.
Chairman, if I just follow up? And again, I remind the committee, I'm not going to be here to vote on this. And if it passes out of committee, I'm just trying to alleviate some of the heartburn that's going to be on the floor. And that there's going to be opposition to it. And if we can alleviate that, I mean, that's what I'm after. So if there's a better term, I agree with you. The term that you just mentioned, it means the same thing. So I can't think of one, but thank you.
Senator Bouchard.
Thank you, Mr. Chairman. You know, I'm having a same problem with the list of what we will allow. And so under the, I mean, I just Googled things on my phone to look at what I mean, I'm not a medical professional, but looks like PRK, which was a predecessor to LASIK, would be included in this bill. And so I'm kind of, how does someone go learn how to do PRK, and how many hours is it, and where do they get that degree, or what is involved? I just wonder how we narrow this down to different procedures. I mean, I don't know if that's really a question there, but I mean, it's could you explain to us what PRK is and how, if that's included in here, and how long does it take to learn the scope of practice for that?
Chairman Scott, Senator Bouchard, as I see currently within the language within the bill, then PRK or photorefractive keratectomy would currently be allowed within this bill. As far as the coursework, there are optometrists within the state of Oklahoma. They do perform that. They have gone through that education process. I haven't looked specifically at the details on that education, the number of hours that would be involved in that. So I don't have you a specific answer on the number of hours for that certification on that. But as it is right now, I do see that within the bill that would be allowed.
Thank you, Mr. Chairman. Just to follow up. Well, PRK and LASIK are very similar. So, I mean, LASIK would also be in this bill. So I'm just trying to come to the conclusion, if we don't have any kind of set, I mean, because we do this on other licensing, we actually have training specifics. So, I'm thinking we're going to do something that's a procedure, but we're not narrowing it down to what the training is. So that's.
Let me ask a question at this point. Senator Bouchard, where's the PRK language? Do you give me page and line number?
Mr. Chairman, I don't have PRK language, but basically what the bill does is allow PRK in the language of the bill, but PRK is a procedure.
Okay. Senator Ryan?
Yes, Mr. Chairman. I'm trying to think back to 2004 when I actually had that surgery performed, and I'm looking at page 4, line 14, and I'm just wondering, does PRK or LASIK not fall under the retina laser procedure? Please lie me, because I don't know much about it.
Senator Scott, Senator Boner, no, retina would be further back. When we're talking about LASIK or PRK, we're talking in front of the eye or the cornea. So those are separated there. And I just might add that as we look at the bill, the the issue of PRK or LASIK is something that I think is an association. We can certainly add that as an exclusionary item within the bill. That would not be, heartburn for us.
And Ms. Chair, I just say that'd be an easy amendment on page 4, line 14 there to add corneal in some form or fashion.
Okay, if you want to bring that up,
yes.
Just do it. Okay. Optometrists, anything further? Questions, Representative Halverson.
Thank you, Mr. Chairman. Wouldn't the scope of inclusions be included in the board's determination? Someone, a practicing optometrist, would have to be specifically licensed for that, or would it be included generally in the scope of practice from this bill? Could, put another way, could your board specifically exclude that in its rules and regulations? I'm worried about putting more exclusions in this bill as they say technology advances.
Chairman Scott, Representative Halverson, perhaps the board may be best suited to answer that specific question as they deal with the rulemaking process and how now in that process. I think they can best answer that.
Anybody else? Dr. Hallinan.
Thank you, Mr. Chairman. How many optometrists are there in the state of Wyoming?
Senator Scott, Representative Hallinan, the Wyoming Optometric Association has 105 currently active practicing doctors that are members. That is roughly 98% or so of the licensed actively practicing optometrists in the state.
I have a follow-up for that, Mr. Chairman. How many optometrists in the state do you believe are going to be performing LASIK or PRK treatment on patients? How many do you think are likely to do that?
Senator Scott, Representative Hallinan, I don't know if I would be able to put a number to that. One of the things with the scope is we do know we have 100% of our membership on board with what we're presenting today and what the scope would be. Whether all of those optometrists choose to go through the advanced procedures training in 10 years, become advanced certified in order to do those, I cannot say.
Well, let me see if I can clarify and ask if I've got it right. As I read the language on page 4, the number that will be doing retinal laser procedures is absolutely 0 because that's on the prohibited list. Did I get
Senator Scott, correct, but we did just establish that LASIK and PRK are not retinal laser procedures. So they are still currently allowable if trained.
Okay, I thought they were, but no.
Mr. Chairman?
Okay, so we may
I have another
amendment.
follow-up question.
Okay.
How many optometrists have already undertaken the training that the board is prescribing for these procedures?
Senator Scott, Representative Halverson, we offered an advanced procedures course that would max out at 50 for the lab, and we had 48 of our optometrists take that. These are 48 optometrists who were not already certified to do those by way of their education.
Further questions? Further questions? Optometrists that cover? Okay, thank you very much. We may stand by. We may ask you further questions. This proceeds. Medical Society, you're next. Ask him why they didn't come to the field. I'll let you do that.
Good afternoon. My name is Dr. Ann Miller. I have Dr. Nottage here, Jennifer Nottage, Laura Lewis, and Dr. Matthew Dodds. Chairman Scott, Chairman Barlow, and members of the committee, thank you so much for this opportunity to address your committee. Again, I'm Dr. Ann Miller. I'm an ophthalmologist. I've been practicing ophthalmology in Cheyenne, Wyoming for over 17 years. I'm here on behalf of ophthalmologists throughout the state and serve as president of the Wyoming Ophthalmological Society. I also am here to serve as a patient advocate. The Wyoming Optometric Association has brought us together throughout this interim to address their Practice Act. While I concur that there is room for improvement by simplifying some of the language in their act, I still, to this day, do not understand why they are asking for such a major overhaul. The American Optometric Association has been and continues to push for expansion of optometric practice throughout this country. I am concerned that Wyoming is falling prey to a national agenda and their tactics of oversimplifying laser and surgery or advanced surgical advanced practices, whatever we want to call it, on and around the eye. Optometrists and ophthalmologists in Wyoming and bordering states work together to serve the eye care needs of Wyoming. There is no access issue. We have met with our optometric colleagues about this bill several times, trying, first of all, to understand what is the need for their ask, and more recently have met and in order to try to find compromise language with regard to prescriptive authority. These efforts were not successful. They said they were happy with the bill as it is. Each of you have a very heavy responsibility. When you took your oath of office, you pledged to discharge the duties of your office with fidelity. I too, we all took an oath as well, that of the Hippocratic Oath, when we graduated from medical school and became medical doctors. With that oath, we pledged to practice medicine ethically and to put patient welfare and safety above all else. It is up to us to stand up for what is right, protect patients from harm, ensure their best chance of safety, and maintain the standard of eye care no less than what Wyoming has received heretofore. Over the last few months discussing this bill with you, we have heard things like, we want optometry to be able to take advantage of technological advances. Well, let's consider really what they're asking. They're asking for lasers and surgery. So lasers have been used within the field of eye care for over 30 years. That is not new technology. And we all know that scalpels and needles are nothing fancy and new. The fact is, optometrists already enjoy access to technological advances right in their own offices when they use the high-tech imaging devices in order to diagnose disease and treat and follow disease. I find it ironic that just 2 sessions ago, optometry was before you running a bill to prevent use of advanced technologies for eye exams, and now suddenly they want to embrace technology. We have heard that we need to change their act to keep up with changes in their education, though we still have yet to hear the details as to what is happening in these optometric schools that is far different than previous to allow them to do these many more things. But in reality, this education that apparently is going to suffice to safely provide care to their patients consisted of the 32-hour weekend course given last month in Casper. I encourage you to consider the disparity in education between ophthalmologists and optometrists, and hopefully you have in front of you this chart here depicting the difference in education between optometrists and ophthalmologists. Granting Wyoming optometrists the ability to do surgery and lasers with such little training would significantly water down the standard of eye care in Wyoming. Would you feel comfortable allowing your optometrist with so little experience to remove a tumor from your eyelid or aim a laser beams of high energy light to cut tissue inside of your eye? Would you want to be their first patient? Well, someone's going to have to be the first patient, because within this weekend course, there were no people that they got to learn on. Far different from the education that we have throughout our years of residency, where from day one, we're in clinics with supervision of other ophthalmologists who do these procedures. They watch us as we're learning, and it's repeated over and over again, but it's far more than just that procedure itself. Please don't be fooled. There is no simple eye surgery. I find it disheartening that optometrists make it seem that what they're asking for is really no big deal. Trivialization of eye surgery and lasers is deceitful. Surgery is not just the physical act of cutting a laser, cutting tissue, or firing a laser. The extensive education and hands-on experience that ophthalmologists endure don't just allow the acquisition of the technical skills needed to perform the procedure, but just as importantly, what you're learning is the clinical foundation necessary to decide what patient is the appropriate candidate for the procedure. And when it's appropriate to intervene, on whom, and what to do when things don't go as planned, how to handle those complications. We don't really need that many more people performing procedures that are already being perfectly adequately taken care of by the ophthalmologists throughout this state and bordering states. As a physician who aims to do no harm, we're constantly balancing risks and benefits before even offering a procedure to patients that could potentially cause harm and/or blindness. Appropriately crafted practice acts are the public's assurance that they will be treated with a high standard of care consistent with the majority of the states throughout this union, not a small minority. Patient safety is of the highest concern, not only for physicians, but for all of you who have to decide this very important topic. Please remove surgery and lasers from this bill.
Okay. Any questions? Okay. Anything else?
Yes, Mr. Chairman, Laura Lewis with the Wyoming Ophthalmological Society. I have one handout for LSO. And to be brief, my comments are just to follow up on comments made earlier this interim in October regarding the need for this particular legislation, so not to make Wyoming an island, to modernize because it's been so long, and to not leave us out of this momentum throughout the nation. The first image you'll have on your handout is one that the American Optometric Association put out, and I recently found from an October digest that speaks to scope in other states. And I think you'll see from this handout that Wyoming is hardly an outlier currently. There are 12 other states that have greater restrictions on the optometric scope. Wyoming is alongside most states, vast majority of states, in that second to the outer band. The current bill before you would push Wyoming to the very edge of that diagram, along with only 3 other states. And I would argue that actually makes Wyoming quite the outlier. I think right now it would be difficult to argue that we are. And I want to reinforce that since this ask was made and brought forth last May, we have sincerely sat down with optometrists to say we are not opposed to any changes to that Practice Act. We recognize there are spaces that probably could provide more convenience for patients, and that wouldn't compromise safety and standard of care. And we have been and continue to be open to having those conversations. Very specifically, the red line is on surgery. And just for one other, the second page, the line graph is really just designed to address the issue of access. We also have heard that the recruitment concerns without expanding scope. You will see that the numbers of ophthalmologists and optometrists by state aren't really driven by scope. They're driven by population. You'll see from that line graph, the very states that have expanded scope nearly completely or completely are right along the same line as the rest of us as far as proportion of ophthalmologists and optometrists to population. Wyoming is not an outlier in that case either. So again, we go back to just wanting to have a better understanding of what the real problem is that we're trying to solve so that we can come to a conclusion that puts patient safety at the forefront.
Thank you, Mr. Chairman. Correct me if I'm wrong, but I thought the problem we were trying to solve is that when optometrists came back to Wyoming, we were only putting out half a welcome mat, that they are not allowed by their current scope of practice to practice all that they have learned. Is that not an accurate statement?
Mr. Chairman, Representative Halverson, we would argue that there may be conversations in training about procedures, but without the extensive hands-on training that Dr. Miller referenced in residency, where before you ever cut on a patient, you observe a certain number of procedures, then you assist, and then even before practicing independently, a certain number of times you have to be supervised by your instructors and the licensed ophthalmologists. And so it's not to devalue the conversations and the training they receive with specific to those procedures, but it's also to stress the value of that hands-on training and supervised training.
Last year, Wyoming spent $160,000 on the education of 9 Wyoming optometric students. Do you think we could probably save half of that by telling them, skip this class, skip that class, don't go for that training, save Wyoming a little money? I don't understand how all of these, 28 schools of optometry in the country can be training these optometrists, and you're dismissing that training because it's not hands-on enough as a medical doctor would get. I heard the word deceitful used earlier, and I don't appreciate that. I don't think anyone's being deceitful with us. But why do you think Wyoming spends money on its witchy students when they can't practice half of what they've been trained? Why should we continue doing that?
Mr. Chairman, Representative Halverson, I think the same could be said then of the reverse of WWAMI students and ophthalmologists in general. Why continue with medical training if you could go to optometric school and be an eye surgeon? The private sector isn't further limiting that training because optometry can do it in 32 hours. There's a value to that, and I don't think Wyoming is taking away a welcome mat. I think you'll see from that line graph that a lot of other states have not expanded scope, and they're not losing, they're not unable to recruit optometrists. Wyoming continues to have new optometrists come into the state and open in young ones, and it's a great addition to our communities. I think in the last 3 years, there have been 26 attempts to expand optometric scope into the area of surgery. And of those 26 attempts, no state legislature has passed a bill that specifically expands their scope into the area of surgery. And it's not because they weren't willing to welcome optometrists to their state. It's just they can't discount the patient safety and the training.
Did I miss a question down this side earlier? I was going to make it.
Thank you, Mr. Chairman. Just two, I guess, general questions, each dealing with a page of the handout. First one, heard the comments on safety issues, and to be clear, that's a very serious accusation. To imply that a medical professional, whether they have an MD or not, is going to do something that's unsafe for their patient. And so I was hoping that you could substantiate that claim. And looking at those 3 states, admittedly, there's not too many of them, but there should be a some evidence if there is danger in allowing for the laser procedures as known on this graph. What are the evidence do you have to support that accusation?
Mr. Chairman, Representative Boner, frankly, there's a bit of a head scratcher in this whole ask, and you speak to it. Why aren't there awful outcomes in those 3 other states? When we've looked at data, it appears a very, very small number of optometrists are even doing these procedures. They're ophthalmologists doing it. And we would argue because the training isn't sufficient to then build that confidence to cut on the human eye. Again, we would rather these efforts to amend statute be driven by a local need. And we still question what that might be.
Thank you, Mr. Just to, I understand if we could have if there's any indication just how many procedures have been performed by optometrists, any sort of hard data, that would be useful. And so I heard that because I'm guessing if there was an issue, we'd probably be hearing about it. So there haven't been, as far as your research goes, you haven't heard any of the actual issues, safety issues regarding optometrists who have performed surgery up to this point. Is that correct?
Okay, Chairman Scott, Senator Boner, and also to address your concern, Representative Halverson. So I think something that's so difficult about this whole subject is that we haven't been provided good specific information as to truly what an optometric education looks like. But understand that optometry school is not a surgical program, whereas, again, we go through medical school, but throughout our residency, we are dealing with patients, seeing patients day in and day out, again, assessing the whole condition to know who is a surgical candidate, and then performing these procedures first, observing them. So I think, I appreciate Representative Halverson, what you're saying, and I appreciate the fact you take offense to what I've said. But the fact of the matter is, and I would hope that the optometrists would help to clarify this very confusing subject of what is this education. But throughout the optometric schools within this country, to my knowledge, and of course, I'm not going to admit that I'm expert in this area whatsoever, but in the research I've been able to do and understand is such that the optometric school in Oklahoma is essentially the only program where those optometrists can come out of the program and do lasers and do a limited number of eyelid procedures. So I think we're kind of generalizing and with what this bill does as well, which would allow for a whole lot of stuff that could be done, but yet there isn't the support and education to qualify anyone. And I don't know how in the world an optometrist would feel comfortable doing procedures without that background and training and experience. But again, it just seems that I do not feel, aside from the weekend course that they put on throughout the country to certify optometrists in certain lasers and some discrete eyelid procedures. So what this bill, the risk of this bill is such that it really opens up a whole lot of procedures that could be done without any, though there are checks and balances, and I do appreciate Chairman Barlow's restructuring of a board, but let's look at it. It still has the majority, 3 of 5, the majority representation is that of the optometric voice. So I hope I've kind of helped to clarify where this concern for safety is. It's because they do not have the experience in working on humans. It's a didactic lecture, slides and whatnot. But until you perform a procedure on a patient, and thank goodness you have people around you that are competent and skilled to help guide you and to train you and your eyes and your brain as you're learning on people. Without that, I don't think it's anyone's business to subject a person to the risk that could ensue.
Okay. Representative Hallinan.
Thank you, Mr. Chairman. I have a couple of questions. I'll ask the first is, How many ophthalmologists are there in the state of Wyoming?
So there, at this time, are around 11 ophthalmologists. However, understand that this state of Wyoming, with regard to eye care, just as it is in so many other fields of medicine, are served by practitioners, physicians, ophthalmologists in this case, across state lines. And so that number, there are a number of ophthalmologists who have Wyoming licenses that practice within the state. And I regret to say that I do not know that number, actually.
My next question, Mr. Chairman, is I would ask each one of the ophthalmologists present to say how many LASIK procedures that they do during a week.
Okay, so just Chairman Scott.
Okay. Go ahead.
Okay, Chairman Scott and Representative Holland. For clarification, there's been a lot of confusion with regard to lasers. So we use lasers in many different applications within ophthalmology. So there are vision correction procedures, which is an elective procedure, and that is the realm of LASIK and PRK. And I'm not going to relate those to the bill, but I just am trying to have a little background knowledge here. And so the lasers that are commonly, the lasers that they're trained on in their weekend course include lasers, 3 major different ones, one of which is probably the most commonly performed laser, YAG capsulotomy. It is performed and people after cataract surgery can develop a film behind the lens implant, making their vision cloudy again. And so that is a laser where we make a little opening in the filmy area to clear the path for vision. The other 2 lasers that they would receive just over an hour of training on in this weekend course is a laser done to help lower eye pressure. And then finally one to help open up and deepen the space where the fluid needs to exit from the eye in order to help prevent, it's not to treat, but rather to prevent an attack of angle closure. I am a glaucoma specialist, and the laser to help lower pressure is something I do very commonly. And so I would say on average, I perform between 10 to 15 lasers of these 3 different kinds, not PRK, not LASIK, but 10 to 15 per week.
Chairman Scott and Representative Paladin. So for me as well, it's somewhere in the range of 6 a week for those 3 types of procedures. I do also perform LASIK and PRK, but it's just on the tune of just a couple of months.
Chairman Scott and Representative Hallen, and I actually perform probably about 15 procedures a week in that realm.
Okay.
Thank you.
Okay. Any other questions? And committee, remember, the longer you talk, the longer we'll be here. Senator Peterson and then Senator Bonner.
Thank you, Mr. Chairman. According to the chart here, Wyoming's one step behind most of the other states, and that it just drops short of laser procedures. So my question is, seeing we have 25% or just over 25% of our ophthalmologists here represented here today with you 3, would your association be content just stopping short of the laser procedures with these optometrists? And that would bump us up to all these other states, just short of the other 3 that do allow laser surgeries with optometry.
Chairman Scott and Peterson, there we go. Sorry, this is not my usual environment. Usually I'm telling somebody how I want to whack on their eyes. So in any case, one of the things I've learned is that, you know what? You don't know what you don't know. And there's a lot of procedures that are listed in there. Let me tell you about my experience when I came before this committee the last time. I cut my schedule way back to make sure I was here on time. I had 5 patients, all of them cataract evaluations. 2 of them, great cases. Okay, they really needed surgery. They would fail their driver's license test. 3rd one had an epiretinal membrane that was accounting for their decrease in vision. Should never have made it to my office, should have been at Dr. Holmes's office. Number 4 had a tear in the retina. That's what needed to be addressed. And I don't know how long it had been there, but clearly you have to manage that before you do surgery. The last one, I stood in the doorway and I said, "Oh, you're here for your eyelid." And she said, "No, I'm here for my cataract." I said, "Really? Let's talk about that dime-sized cancer sitting on your eyelid." She's having reconstructive surgery in Colorado. You don't know what you don't know. That would be my point.
Mr. Chairman, if I could also address Senator Peterson's question, please. I would say in our offer back in May, and then the formal offer to the committee and ask of the committee in October to find common language on prescriptive authority, I think does exactly what you said. Expanding their prescriptive authority pushes us to the outside of that band and in line with all those other states. That is what you see elevating those states, is that they have expanded the prescriptive scope. And that's the area we absolutely are comfortable having that conversation.
Thanks. Mr. Ball.
Okay, just follow up on Representative Hallidan's question. When I had my PRK surgery, so I could, reach a certain qualification for the Air Force, it made me think of those 11 ophthalmologists. How many are at the VA center? And is there any difference to the best of your knowledge? Everybody here is from Cheyenne, right? No, not almost. Okay, almost everybody. So, to your best of your knowledge, is there any difference in volume if there are any folks doing those sorts of surgeries at the VA center here in Cheyenne?
Chairman Scott, I'm sorry, Senator Bonner, could you please restate your question?
So that you said there are 11 ophthalmologists. Are there any at the VA?
Oh, Senator Scott, yes. Senator Bonner, yes, there are currently, to the best of my knowledge, 2 full-time ophthalmologists, comprehensive ophthalmologists at the VA. They may here in Cheyenne, and then I do believe they have also a retina specialist.
Are those in your count of 11?
Senator Chairman Scott, they are not in that count. And as far as the exact numbers, but I think the bigger point here is that the needs of Wyoming's eye care are currently being met. We have not, in our conversations with optometry, never have they delineated and described the way in which the eye health of Wyoming is being compromised because of their current act. Understand the procedures that they are asking to do are non-emergent procedures. We're talking a sty on the eye, a chalazion. Well, most of those resolve with conservative local management, which any optometrist, ophthalmologist, family practice, pediatrician, what have you, can initiate that treatment. It is not at all an emergency that you have to incise and drain a sty. These lasers, as well, as I mentioned, are non-emergent procedures which are scheduled on an elective basis. So again, we're not understanding the need to drastically change a Practice Act, which has worrisome loopholes and areas where additional procedures could end up being done under the oversight of either all optometric or majority optometric board. The worry for patient safety is paramount.
Anybody else? Okay. Representative Halverson and then Representative Hallinan.
Thank you, Mr. Chairman. Can you point out some loopholes in this bill?
Chairman Scott, Representative Halverson. So with particularly an exclusion list, that's where I'm referring to a loophole in which there are procedures that are not delineated here, that certainly the weekend course in Casper is not going to sufficiently prepare any person or optometrist wanting to perform these procedures. For instance, glaucoma procedures. If you look at the exclusion list, one could perform glaucoma procedures. Those, like surgical procedures, those are things that even comprehensive ophthalmologists tend to shy away from because they they're number one, difficult procedures, and number two, the management of those patients can be extremely complicated. The risks of blindness or severe vision loss are great. So we can, go through but that's my concern, is that number one, the training is not sufficient, and number two, the way in which this is written is such that it opens up the potential for procedures to be done which hadn't been thought of.
Follow up. Short
Okay.
one. Short one, I promise. Am I still on? We had a discussion this morning about the leakage of patients to other states. Do you not agree, the four of you, that it's better to keep patients in Wyoming than send them to Idaho Falls and Fort Collins and Salt Lake?
Mm-hmm. Chairman Scott, Representative Halverson, I couldn't agree more fully. I find it disheartening that, and this is hard to say because we all work as a team to provide eye care throughout the state. But here within this community, optometrists in Cheyenne routinely will send cataract patients to Colorado. And I, not infrequently, will have these patients in front of me and they tell me their frustration because their optometrist said, I recommend you need to go to Fort Collins for your cataract surgery. And occasionally they will push that doctor and say, yes, doctor, but my friend went to Dr. Miller and she liked her and had a good outcome. Can I go to her? And then at that point, oftentimes I would imagine then, oh yeah, you can go there. Well, why haven't they these are your options, A, B, C. We all know people who have cataracts are largely an elderly population. So what does that mean? Their child has to take time off from work, let alone the drive and the hassle and the traffic. When we right here within this community, thankfully, are able to serve patients with most any type of eye need. Of course, anything that's very specialized in any field of medicine, you're going to have a need oftentimes to go perhaps down to University of Colorado where you have, specialized heart surgeon for some rare procedure. But by and large, the bulk and vast majority of eye surgery needed by patients can be performed by the ophthalmologists within the state. And yes, it's going to require some travel for some of those that live in outlying areas, that's just understood. But I think it is, I think there is an outmigration that does not need to happen.
Dr. Hallen.
Thank you, Mr. Chairman. I have a question for Dr. Miller. With 48 of these optometrists taking this advanced practice course, this 32-hour course that you've described, how many of these would be likely to do, say, 5 LASIK procedures in a week or 1 laser procedure in a week? How many do you think would do that?
Chairman Scott, Representative, it's hard to guesstimate that. I will say I have had some conversations with optometrists throughout the state, and when I've mentioned, why this bill? Oh, don't worry. I don't want to do lasers. That's expensive equipment to acquire anyway. And, I wouldn't want to do them. And we have seen in other states, particularly New Mexico and Oklahoma and Kentucky, where it's actually a small fraction of optometrists within these states with their expanded scope that actually do the procedures. So it is worrisome. I would imagine that might be a concern of people, that if you suddenly have this larger pool of people able to perform a procedure, then that really waters down the quality of the procedure being done, because we all know that the more frequently you do a procedure, the more facile you become, you're going to be a better surgeon. And so if you suddenly dilute that, then the quality of care is surely to suffer.
Okay, let me at this point see if I can try to summarize things. As I understand the testimony that we're getting, you really don't have great problems in the prescription drug area with this bill. But you do have problems in the surgery area. Now, we sent you off to see if we could get a compromise worked out, and clearly that has not happened. Let me ask you, are you objecting to all surgery treatments by optometrists, or is it just some of them?
Senator Scott, surgery and lasers is our red line. We object to Part C and Part D of version 4. With respect to medications, yes, as you acknowledge, we reached out, we tried to be able to, find common amended language, and that was not fruitful. My concern, this is Anya, I have a couple concerns with regard to prescriptive authority. One, which is also alluded to earlier in the discussion about ascertaining or putting into statute what their education looks like. What's the testing they've taken out, like a national test. It's now diluted to just whatever the board, whatever tests they feel appropriate. But then another concern I have is in page 10, lines 1 through 3, language that describes how they've removed language that states that optometrists would be held to the same standard of care as physicians who prescribe these same medications. I really do not understand why that that would be removed. It doesn't make sense if we're concerned about patient safety.
Okay. Let me ask, and I'm again fishing for compromise. Am I right in thinking that removal of a foreign body from the eye, you get something caught in the eye, that's considered a surgical procedure and all this?
Chairman Scott, it is a, yeah, they can currently remove superficial foreign bodies. I will say that a challenging thing is that if you do not have an astute enough person examining the eye, they might not recognize the fact that that foreign body on the cornea, the surface of the eye, is in fact full thickness, in which case if they go then to remove that foreign body, they have now created an opening from the outside world inside the eye, risk of infection, the pressure goes to 0, and that's an emergent surgical emergency. So, but as far as superficial, so long as it's recognized as such, foreign bodies, those currently can be removed by optometrists.
Okay. Anything further? Thank you all very much. Who else individually wants to be heard on this? Yes, sir. Can I hold you? You've got some amendment. I want to get closer to when we might work those. Anybody else? Anybody else? Medical Society again. Sheila.
Is that on? Yep. Mr. Chairman, members of the committee, Sheila Bush with the Wyoming Medical Society. And to be clear, a very separate organization, although both physicians and ophthalmologists are members of the Wyoming Medical Society. We are the umbrella organization for all medicine in the state, for physicians and physician assistants. And the ophthalmologists have a specialty society, of which their counter would be the optometrists. So for those who are new to the committee, just very briefly, the Medical Society, established in 1903, we represent just under 60% of all physicians in the state, as well as physician assistants. And I don't have the percentage of how many physician assistants we represent. Senator Baldwin may know, I'm not sure. We are not new to the scope of practice conversation, as you all know. We find ourselves in these debates often, and I would urge the committee to remember that the Medical Society in the last close to 9 years, that at least I've been the director, has been an organization very friendly and open to a lot of these scope of practice bills. We have partnered to license acupuncturists. We have partnered to license lay midwives. We helped, I think, come to a compromise with physical therapists, and even sat by their side to encourage their expansion and to remove some limitation on them. We also, I think we stood next to nurses and nurse practitioners in the nursing compact. And I won't go on, but I think sometimes there is a notion to believe that the Medical Society says no to everything and that we attempt to kill everything. And that is, in fact, not the case. And if it was 2 decades ago, that was 2 decades ago. And so with that, I think the only reason I stress that and want to underscore that is that we try to be incredibly thoughtful. Our organization can't take a position without full support from our board, which was representative of all specialties. And in doing so, when we do come to a proposal or a question, we do try and give a very thoughtful response. And in this situation, the Medical Society has agreed with ophthalmology that surgery is a concern for us. We're alarmed at some of what is being asked, but very willing and open to talk about the prescriptive space and some other updates and clarifying language in their statute. I would also be remiss to not highlight the investment our state makes in training medical students to the tune of $12.5 million every biennium, which greatly, I think, speaks to our commitment to medical education and having physician expertise be in Wyoming. And so with that, I think that the state legislature has made a statement about how important physician care is and the role the medical community plays in our communities. And I think that decisions that are made here in this body, they not only send a message to the 2 provider groups in question. Today, it happens to be optometry and ophthalmology. But every time these questions come before you, you send a message to the medical community of how much you value medicine, how much you value physicians, and how much you value the training that they undergo. And so when you look at a student, very smart, coming out of the university, debating whether or not to be a physician and come back and practice here in the state, or to go into another very respected healthcare profession, they have to weigh the pros and cons of that. And every time this legislature makes a decision that relates to scope of practice, you send a message to the physician community that maybe we don't value those 4 years of medical school and a year of internship and sometimes 6, if not 7 years of residency, and then fellowship beyond that. Maybe it doesn't matter. And I don't believe that that's your message, but sometimes a lot of things can be taken out of context when it leaves this room. And I want to make sure that everyone is mindful that it's difficult to recruit physicians to Wyoming. We don't have the best tort space. It's not always easy to get spouses to come here, even if the physician is passionate about coming back. Sometimes the wife says, or the husband says, there isn't any shopping and we don't have a Whole Foods, and where's the Trader Joe's? And so when we do get physicians here in the state, they've passionately committed to taking care of Wyoming patients. And I just hope that that's in your mind as you make these decisions about this and others, that it is important and it means a lot. And then with that, I would stand for questions.
Representative Sweeney.
Thank you, Mr. Chairman. So I thank you for that. But in the testimony provided by the ophthalmologist, I almost got a takeaway that the optometric folks on some of these procedures, while there's no proof or evidence of I guess it'd be malpractice, their training is less than adequate to even spot. I'll use the word a bunch of nincompoops because in my layman terminology, which I really don't think was appropriate in the statement. So I'm wondering, do ophthalmologists, in your opinion, from the medical society, ever have issues on diagnosis, just like the optometric folks might have misdiagnosis? Does that never happen between the two professions in comparing?
Mr. Chairman, Representative Sweeney, I think there's a few parts to your question. The first is, do humans make mistakes regardless of their titling or education? And the answer is absolutely. We are all fallible humans and we make mistakes. I think what's important to highlight is as I've worked at the medical society, I've grown a great appreciation and admiration for physicians in the more that they subspecialize and the more that they train, the quicker they are to defer to another provider. I've never seen a group of individuals so quickly say, oh goodness, this isn't my lane. This isn't my area of expertise. This needs to go to a subspecialist. And I think that it speaks to that training and the experience where when you know this much, you know how much can go wrong. And you recognize the liability space, admittedly, but also just their obligation to taking care of a patient. And so you heard Dr. Dodds this morning say, or not this morning, it felt like this morning, a few minutes ago, say he had 5 patients. 2 of those, he performed the surgery that was referred to him to perform. The other 3, he made different decisions, and one of which he quickly referred to Denver. Because and he has, by statute, he could have done a procedure on that patient, but didn't, because they know they have the breadth of knowledge and the depth to say this isn't, I'm not the very best because I don't do the procedure frequently enough, or I just don't have that expertise. It's not that I wasn't trained in school and that I don't by a textbook know maybe what I should or shouldn't do, but today the patient means more and I'm going to get him to somebody who does this more often. And I think that happens a lot. And I don't know if that answers, but are they fallible? Yes. If that was your question, do they make mistakes? I'm sure they do all the time.
Anybody else? Anybody else? Anybody else? Representative Halverson.
Thank you, Mr. Chairman. So along the same lines, is there a feeling among physicians, MDs, that optometrists don't know their limits? I mean, we've got 4 pages of what they don't know in here. But are optometrists unique in that they won't say this is beyond my comfort zone, out of my lane, and I will refer you either to another optometrist who has more experience or perhaps an ophthalmologist?
Mr. Chairman, none of this conversation is intended to be pejorative. And if any of the words you heard from physicians today felt that way or had a tone of offense, that is not our intent. These issues are emotional. They really are. What was that? Okay.
I don't think it's emotional. I think it's very technical.
It's incredibly technical, Mr. Chairman. But to say that we can strip these conversations of the emotion of someone's livelihood on both sides, I think is maybe naive of us. And so there is not any intent of saying one is lesser than the other. There isn't a better thans and the less thans. That doesn't exist. It's not appropriate. Wyoming patients depend on these 2 groups working together and having a solid relationship. And it's our job, the medical society, both of the specialty societies, the legislature, to ensure that when March of 2019 rolls around, regardless of the decisions made, we all go back home and put patients first. And so these conversations get tough and they get sensitive. And I argue they get emotional. But that's our job. And that's what a lot of us signed up to do.
Is it safe to say, and in my experience, it's been true, that these two professions refer patients to the other profession all the time? That the ophthalmologist will refer patients particularly needing eyeglasses, in my experience, to the optometrists. And the optometrist will refer patients needing more specialized care to the ophthalmologist. Am I not right in thinking that's normal working practice in the state?
Mr. Chairman, you're absolutely correct. And it does also inform why this particular debate through the years has been a little more contentious than some of the others. Because at the end of the day, ophthalmologists are dependent on their optometry colleagues for those referral patterns. And optometrists arguably less dependent on ophthalmology, which is what you heard earlier, which is you have optometrists within the same community referring around their ophthalmology colleagues to go out of state for a variety of reasons. We could go in another time. But the answer to your question is yes.
Okay. Thank you very much. Anybody else before we get to the optometry board? Anybody else? Mr. Bonneblast.
Mr. Chairman, Kevin Bonneblast, Executive Director of the Board of Medicine, and I promised myself I wouldn't say anything today, so I broke my promise. But I just wanted to give the committee another information point. The latest figures that I pulled prior to your last meeting in October, in addition to the 11 ophthalmologists that are licensed and resident in the state, we have about another 40 or so that are licensed in Wyoming, carry a Wyoming license, but we consider to not be resident. So you've got that perspective. And then to Senator Boner's question about physicians, for instance, at the Veterans Administration or Veterans Affairs, excuse me, they don't necessarily have to be licensed in Wyoming to be working at the facility, say here in Cheyenne. So they could very well be licensed in another state using that other state's license at this facility. So that may account for why they wouldn't show up on our licensing list, for instance. So I wanted to give the committee that perspective so you have a little more data point there.
Okay. Thank you. Thank you very much. Anybody else? Anybody else? Board of Optometry.
I think that's on. Mr. Chairman, committee, my name is Kobe Ramsey. I'm an optometrist out of Rock Springs, Wyoming. I'm the president of the Wyoming Optometric Board. I have with me Dan Perella. He's our secretary treasurer on the board. He's an optometrist practicing here in Cheyenne. We have Emily Kornboss. She's our executive director for the Board of Optometry from the state. We have just a couple of amendments that we wanted to address. One was the allied healthcare professionals. We just want to make sure that that was licensed healthcare professionals. That was the only thing we wanted to add, and I think you covered that adequately. The other one,
that one is on
page 10, line 13, 14.
Okay.
The other one, we had some opinions from different people about the ability to prescribe fees. And we looked at some of the other licenses that we have, and we found this one in acupuncture. And they have a line that says prescribing fees in accordance with WS 33-1-201 for implementing this chapter. And we were hoping maybe we could implement that into the bill. And we were looking at page 11, line 11, just at the beginning of that section. Don't really know where would be a good section for that, but we just felt that the ability for us to prescribe fees for testing and licensure, we just wanted to make sure that that was in there specifically.
Okay, so you're not talking about somebody writing a prescription. You're not talking about regulating.
Nope, just the ability for us to get fees.
You want to set the fees for.
Yeah, that's correct, Chairman.
Okay, and where do you want to put that?
Well, it looked like page 11, line 11. I guess that's the best place to put it. I'm not sure. If you want to throw it at the end of that section, that's fine. But it's just, that was the same sentence that we found.
You have specific language to offer
Yes,
us?
it's from acupuncture. Do you want me to just give that to LSO?
Yes.
Okay, we'll give that to them when we're done. Just some other questions that came up, why we had specifically a national licensing board and why we want to take that out. That seems to cause everyone a bunch of heartburn. We're actually a member of ARBO, which is the American Regulatory Board of Optometry, which is a member of FARB, which is the Federal Association of Regulatory Boards. And so ARBO is the one that recommends licensing and basically what the licensing procedure should be. At this point in time, it is NBO parts 1, 2, and 3 as it currently is written. But we've found from some other professions that we've talked to, if you have that specifically in statute and something happens to that test, how are you then going to license and make sure people have passed a certain level of competence in order to practice in the state? So we're not asking to shortcut any testing. If anything, we might even make it a little more difficult, especially since if the law passes as written, we're going to have to put in a section on advanced procedures and what that's going to take. So we're not asking to get rid of the National Board of Examiners of Optometry test. We just want to have the flexibility in case something changes or, heaven forbid, NBO, goes out of business. And as far as licensure, what we would do, the question is what we do with somebody who is practicing in another state, 20 years out of school. We do it the same way you do anything right now, and even how medicine does it. You'd look at it and say, well, what is your state's license scope? If they come from Oklahoma, well, then they've already been practicing at the highest licensure level. We won't have to do anything. If they come from Hawaii, then they're going to have to do significant changes or show that they've had education in those areas or passed all part 3s of the board, all three parts. Sorry, I haven't had anything to eat since 11. Have not passed all 3 parts of the national board, then they're going to have to go back and do that. So we anticipate that moving forward in the state of Wyoming for our doctors, if they want to practice advanced procedures and anything like that, that we would set up the guidelines for that. One part of that would be taking the class. And I might add that anytime a new procedure comes out for ophthalmology, I don't think they all go back to school for, sounded like 20 years there a second ago, and then learn the procedure with someone over their shoulder. I think I'm just saying, we do it the same way they're doing it. So I think we would make sure that if a new procedure came out, we'd set up the testing guidelines and make sure that they follow those guidelines and pass those tests. The issue also came up of LASIK or PRK. In the original bill, LASIK was an excluded procedure. I don't know how that got dropped, but LASIK was not an included procedure. PRK was, and that's another one if you want to talk about, you can, but I think in the original draft, LASIK was not, it was an excluded procedure in the exclusion list. Is there anything else? I think that was all we had. So if there's any questions, we'll be happy to answer them.
For the board. Questions for the board. Seeing none. We're back. Thank you very much. We're back on the bill. It seems to me, Mr. Chairman, I heard a motion to introduce the bill. I did not seek a second at that time. You still maintain that motion?
I do maintain a second.
And we have a second. Been moved and seconded. My instinct is to ask for amendments generally and not just walk through the bill, but ask for amendments generally. And I would suggest we start with the 2 from the Board of Optometry on page 10, line 13, Mr.
Chairman, I just want to clarify that I was talking about version 0.4.
Yeah.
That's where we're starting. Okay, thank you.
That's right. There's been a lot of discussion of the language allied healthcare professional. Does anybody care to make an amendment on that? Okay, who's?
Mr. Chairman, so I would strike allied and insert licensed.
Licensed healthcare professional.
Mr. Chairman, so strike allied, insert licensed.
Moved in second. Question I will ask if we get this introduced in committee and the full ed, and are we sure that that's not a fourth optometrist? Because I think the intent is otherwise. But the motion then is to strike allied and insert licensed. Representative Halverson.
Thank you, Mr. Chairman. I was under the impression, and I would ask the mover and the seconder if they wouldn't just rather have licensed allied healthcare professional. Is that redundant, or, I mean, because there are allied healthcare professionals.
Okay, well, we'll ask LSO, but I will say my reading of that is you've excluded having a medical doctor because they're not an allied healthcare professional.
Okay, I see. All right.
Mr. Chairman, I was just going to make the comment that there are various instances in the statutes and in the professional licensing code generally that we do use the word allied professionals. In two different instances, it's defined as to what that means, and in several instances, it's not. Although I think I think that the point may be well taken that it does mean similar licenses, and whether that would include physicians here, I don't know. But it is used elsewhere in statute, and I wanted to make you aware of that.
Okay. Okay, we've heard the motion. Any further discussion? All those in favor of that amendment, say aye.
Aye.
Opposed? That one carried. Now, there was another one, Board of Optometry. It was on which? Page 11, line 11. To put some specific language, and you gave the LSO the language in that section. Co-Chairman Barlow.
Thank you, Mr. Chairman. So the section they're referring to, 33.1.201, is a Article 2, obviously Article 2, that talks about fees and the use of fees by boards and commissions within the entire Title 33. So it gives broad authority to establish fees, and you can go through the language. But this, in the absence of something within their specific act, this would be what they would use. So I think with the example of the acupuncture bill, that was kind of a belt and suspender. I think this already provides them authority if they are not otherwise provided that authority to do fees. They want it in the act. I don't think there's any damage to adding it to the act, and that gives us the suspenders we're comfortable with. I think that's fine. So that would be my thought. I think they have adequate authority within this, but if they want the suspenders, it's not a big deal.
Okay. With that optometry board, I would recommend that we say you've got that authority and we don't need to amend this bill further to make sure of it because it's in the general provisions. Okay. LSO staff.
We'll get back to it.
Okay. Okay. Representative Clem.
Thank you, Mr. Chairman. Page 12. We're looking at lines 3 through 8, and what I would suggest, or what I move, is that we strike the new language on on lines 6 through 8, reinstate the old language, and on line 5, change the and to or. And if I get a second, I'll explain it.
Do I hear a second? Somebody, a second, and then we'll get the.
Second.
Okay, we got a second.
Thank you. Thank you, Mr. Chairman. So really what we're doing here is the old language specifically says on line 3, required to pass the examination series. The new language says it makes it an examination, not an examination series. What I'm hearing from the Optometric Association is they want some latitude to go with the best kind of testing. And so simply by changing the and to an or allows them to do that. So it would read, the language would then read, the examination series administered by the National Board of Examiners in Optometry or its successor agency or any other examination specified by the board in rule. It says the same thing that the new language says, and I think it makes that fix. Furthermore, when we're talking about some of these advanced practices, lines 19 through 21 really kind of designate what those new practices might be. The board shall determine additional testing, licensor, et cetera, for those new advanced practices. So I think just that simple fix from and to or accomplishes what we want to do without adding all that new language and kind of mucking up the bill.
Yeah, and it does seem to me that your proposal is in accord, Board, if I'm right, with the practice that the board intends to follow. Okay, everybody understand this amendment? And this amendment, all those in favor say aye.
Aye.
Any opposed? That carried. Anybody else? Representative Hallinan.
Thank you, Mr. Chairman. I move that we strike item C and D on page 3, 4, and 5, and 6. And the reason for that, Mr. Chairman, if I have a moment, I'll give you my reason.
Okay, so you're going to delete starting on page 3, line 21 through the bottom of 6?
Right.
Okay. Little house cleaning.
Yes, thank you, Mr. Chairman. I think that we heard enough testimony here today to say that the training that is available to the optometrists is really not sufficient to be performing surgery. I would say, using the example of the number of procedures done by Dr. Miller on LASIK surgery, doing 10 to 15 per week, and the fact that 43 of the optometrists took this advanced practice examination or training. If 43 of these folks are going to be performing LASIK surgery, that's going to dilute the capability of physicians who provide a lot of procedures in that area. And I think that the amount of procedures that would be performed by these 43 optometrists would be not enough to maintain their skill level. And I think we need to look at this issue as an issue of our role to protect the patients of Wyoming. And these practitioners would not have enough practice to be providing these procedures. Therefore, I think that we ought to take our role very seriously and decide that they should not be performing these procedures, and that the procedures should be performed by these practitioners who provide these procedures on a frequent basis. Just like we talked about the number of physicians that we have, or the number of patients that we have in Wyoming, the number of patients we have is not enough to have a cardiac surgeon in every community of the state. We have one in Casper, and that's the only one we have. And I think we need to look at the needs of patients to have their eye care taken care of. And I don't believe that dividing these procedures into these 43 new practitioners, I don't think that's the appropriate measure that we should take. I think we ought to limit the number of these procedures to the physicians that perform them in a satisfactory number, to do them satisfactorily. And that is the ophthalmologist in our state. So with that, I move this amendment, Mr.
Did I
Chairman.
hear a second?
I second.
Okay, we've got a second. comment, discussion, questions? Representative Halverson.
Thank you, Mr. Chairman. I would ask my good friend from Gillette if he doesn't think that so many of the procedures that are going out of state might come back into state, and therefore thereby increasing the number of procedures that are done weekly or monthly. Something to consider. I would say that by keeping the procedures at home would increase the volume tremendously. So I will be voting no on your amendment, sir.
Thank you, Mr. Chairman.
Anybody else? Senator Baldwin.
Thank you, Mr. Chairman. Just a quick observation, maybe my observation only, but the bringer of the amendment spoke to how we'd heard about the education. I don't know that I got a full enlightenment of exactly what that education was. We heard some subjective talk about what it was, but I don't know that we were presented with exactly what that training was. And I will be a no on the amendment because I don't know what the training really is. And I think it would be of value to this committee to know exactly what that training is before we vote either for or against it. Thank you, Mr. Chairman.
Okay. I want to make a technical addition, if I may, with the permission of the maker and the seconder. In the title, it looks to me like your amendment would need us to remove the phrase starting on page 1, line 2, prohibiting an optometrist from performing specified procedures. Because I read your amendment, that's what it does. That is that all right with you if we remove that from the title as part of the amendment? I think that it no longer describes the bill with your amendment.
Okay. I
Okay.
take that out.
Second, is that all right? Yeah. Okay. So Ella, so that'll be included in the amendment. I did have a substantive question. We heard that this removal of a superficial foreign body from the eye was something they were already doing and seemed to be perfectly satisfactory as long as it really was superficial. By removing this section, I don't think we affect that, but as I read the title, if we did, we could come back in a standing committee and correct that. So unless I see somebody who thinks the title would prohibit that, I would say that's a possibility if we make that, do that inadvertently. Okay, I don't think your intention is to do that, is it? Okay. Anything else on the amendment? Anything else on the amendment? All those in favor, say aye.
Aye. Aye.
Opposed?
No.
No. I think the noes have it. Ayes, please raise your hand. 1, 2, 3, 4, 5. Noes? Yeah. Amendment failed. Any further amendments? Senator Bonner?
Thank you, Mr. Chairman. We have a very short amendment on page 4, line 14. After retina, add the words "and corneal."
Page 4, line 14.
Yes.
And retina and corner or
corneal. And corneal. That's
let me suggest to you, if I understand the amendment, I think it would probably be or corneal so that you would get both of them.
Yes, that's correct. Sorry.
And otherwise, you're just prohibiting one that does both.
Correct. Okay.
Okay.
I meant or. Thank you, Mr.
Or corneal. Is there a second to that? There is a second. Okay. Explain.
Okay, so Mr. Chairman, I think this is an opportunity after 2 or 3 meetings to find some a little bit of common ground, a little bit of compromise, meaningful compromise. I'm offering the amendment in that spirit. I'll be honest with you, Mr. Chairman, if this comes across the Senate floor and there's an amendment to delete or corneal, I'll probably vote for that until there's actual evidence that there's a risk of corneal laser procedures and that the safety concerns are in fact legitimate. So I'm open to that evidence if it's ever to be presented. But in the spirit of compromise, I thought I'd offer this amendment so we can have a good place to start going into the session if the bill moves forward.
Mr. Chairman.
Clem.
Thank you, Mr. Chairman. I know what the bringer is getting at. I think we were talking about the PRK or the LASIK surgery. And that's what I'm getting at. I don't know as far as with corneal though, if that is my ignorance here. I don't know if there's other corneal procedures that don't include LASIK and PRK though that we are now meddling with. Does that make sense? I just want to.
It makes a lot of sense.
Yeah, I just want to be careful here.
Let's ask the maker of the amendment and then anybody in the audience who knows.
Right, Mr. Chairman, the intent was to get at certainly that procedure and other types of procedure, the assumption being that they'd be similarly intrusive and as a result risky. But like I said, I'm certainly not the medical professional here.
Okay, we understand what you're trying to do. Either the medical professional or the optometrists, are we doing things that the maker doesn't intend to do? Dr. Day. Okay. Okay. Any further discussion on the amendment? Representative Guerrero.
Thank you, Mr. Chairman. I too, seconded that, speaking on and for, in the spirit of compromise, we've sent y'all back twice, and I know shouldn't do this, but I bet I could speak for just about everybody up here and say that we have all the respect in the world for everyone in this room, both the optometrist and the ophthalmologist. You put us in a position by not being able to come into agreement to have us decide for you. And if you don't like the decisions we're coming up with, well, sorry about that. But we did try. And if I had my druthers, if I had a magic wand, I'd make you go back a third time, and I'll be voting that way on final. But right now, what I want to try to do is try to work to get a little bit closer together and hopefully have you all work, as the good senator said, to try to work as we get to session to really working out a solution that works well for both of you. So that's why I seconded the good senator's motion. Thank you, Mr. Chairman.
Okay. Further discussion? Further discussion? Okay, seeing none. Everybody understand the amendment? All those in favor say aye.
Aye.
Opposed? Not carried. One opposed. Any further amendments?
What was that?
Any further amendments? Let me suggest one on page 9 where this is in the prescriptive area. It says, but allowing for the prescription of hydrocodone or hydrocodone containing pharmaceutical agents regardless of schedule. If we were to remove that, that would remove the ability to prescribe hydrocodone. I'm thinking of removing it because I think it does wave a red flag at the rest of the legislature a bit. And I've been told by both ophthalmologists and optometrists privately that hydrocodone is rarely, if ever, justified for the kind of procedures that you do in the eye. So I think it doesn't do any harm to remove it, but I think it does help the bill. So if somebody agrees with that, I'd like to hear a motion.
So moved, Mr. Chairman.
Okay, and the motion is to remove, then in the new language, page 9, line 18, but allowing for prescriptive down through schedule on line 20. LSO, did you get that all right? There may be one other place in the bill where a very similar amendment would be needed. Well, okay. There is a second now. Okay. Senator Bouchard.
Chairman, I just have a question because we're talking about Schedule 2 narcotics and we have the other legislation that's going to, I mean, I'm curious to how that works. If they prescribe, do they get to go into that same system and look at what's been prescribed and in case there's a cocktail situation going on or any of that stuff? So because I don't know.
Senator Baldwin.
Sure, why not? Thank you, Mr. Chairman. Hydrocodone is a Schedule 2. Number one, and beyond Schedule 1 and 2, other practitioners, regardless, can go into that system, into the PDRMP is what we're talking about, the reporting system, and query that to avoid the cocktail situation that you're talking about. So yes, even a physician that doesn't prescribe or a nurse practitioner, whoever prescribes, an optometrist, a veterinarian, has the ability to register for and go into the PDRMP and evaluate those and analyze them.
Okay, thank you. Representative Clem.
Thank you, Mr. Chairman. And I understand what you're getting at. I'm going to be opposed to this amendment. There's two sides of that. And one is obviously we don't want some of these opioids getting into the wrong hands. At the same time, we don't want to stop treatment either. And my understanding is that the optometrist had the power to prescribe this medication before, until hydrocodone was moved from Schedule 3 to Schedule 2 under the federal act. So this is nothing new. This is something that they had the power to do before. The only thing that changed was the federal law. And all we're doing is giving them back the power that they once had. So this doesn't give me heartburn. And I think that, talking about it on the floor in either body is, we can certainly explain it from that point of view. And the second thing, as far as the opioid medication or the opioid task force and some of the legislation there, they'd have to query the PDMP. They'd have to go through some of the same, if we pass some of the legislation there, they'd have to go through some of the same education requirements, and depending on which bills pass. So they would be included in that bunch as well.
Bouchard.
Just to think out loud, and I think as Mr. Chairman, Senator Baldwin triggered some memory here, where they have to be in that system, apply to it, be part of the pharmacy system. So that's maybe why this doesn't matter. But anyway, it's
okay. Yeah, I don't think it is a crucial element in the bill one way or the other. Any further discussion? All those in favor of the amendment, say aye.
Aye.
Aye. Opposed?
No.
Okay. That'll teach me to try and make an amendment from the chair. Anything further on the bill? Anything further on the bill? Hearing none, the motion is to introduce this bill as amended as a committee bill. Call the roll, please.
Representative Clem. Aye. Representative Dayton.
Aye.
Representative Guru.
Nope.
Representative Hallinan.
No.
Representative Halverson.
Aye.
Representative McGuire.
No.
Representative Stivar.
Aye.
Representative Sweeney.
Aye.
Senator Baldwin. Senator Boner. Senator Bouchard.
no.
Senator Peterson.
Aye.
Chairman Barlow.
Aye.
Chairman Scott.
Aye.
10 ayes, 4 noes, Mr. Chairman.
Okay, it is introduced as a committee bill. I will reiterate to the contending parties out there that we will be open as it goes through the process. If you can reach a compromise on some of the contentious issues, that is always useful. Otherwise, you don't know what you might get. Anything further, Mr. Chairman? Do we have somebody else that wanted to talk to us tonight, or that? Okay. Okay. So with that, we're adjourned till 8 a.m. tomorrow morning.
In recess.
In recess until 8 a.m. tomorrow morning. Rest up and recover your sense.